all over the world. Not only in this country, all over the world I have trained surgeon on this technique. So this is called pre-pubic vasectomy, and which I decided, and now you see it is fractional. Next one, you see people कितने intelligent लोग हैं कि ये डस्ट में ये जो पाउडर वाला डब्बा है यहाँ लगाया हुआ है पेशाब रोकने के लिए, देख सकते हैं आप. And see the complications of passing catheter when you cannot do it. So then I designed this instrument known as Sharma's cystostomy set, which is there, and this is a man from England who is getting from me, standing there. Now here is another old man, 98-year-old man. He is 30 years he has utilized the catheter himself. He was doing catheterization himself and without any complication. Now here is a child which I removed in a 65-year-old lady, this frozen child from the abdomen. Now this is third inguinal ring. People ask, Dr. Sharma, ये hernia strangulate होगा कि नहीं? हमने सोचा हमारे पास तो जवाब नहीं है. So then I found that there is a third inguinal ring. If this ring is present, hernia will strangulate one day or the other. If this ring is not present, hernia is not going to strangulate. So tomorrow you operate a case and see this Sharma Singh, any hernia you operate tomorrow. Now this is another Sharma sign of generalized peritonitis. Patient comes with distended abdomen. Is it generalized or localized? Look for the urine. If the urine is orange color or whitish orange, it is generalized peritonitis. And if the color improves, patient will also improve. If color does not improve, patient will also go down in spite of your all efforts. This is a new technique of burn treatment. What I have found that ideal temperature keep a patient with 50 to 60 degree humidity and 25 to 30 degrees centigrade, and just more than 90% burns will also heal without any complication. This is what I have done, and see this wooden made cover I have made in Ladakh. This was how it is. This is an carotid aneurysm I operated, and this is how. This was a connection between the two sides. So we had a chance to operate, and this patient is fine till date. This is another thing, 8-year-old girl before you, and this trichobizarra I removed from the stomach. My anesthetist is also standing by the child. This is how I used to sterilize instruments. Sterilization of instruments, you can see how we do in rural areas, and this is how it is. And 2 deliveries I conducted on the same table, because there was one table only, and एक का मुंह इधर कर दिया, एक का मुंह इधर कर दिया, and both are fine, both delivered nicely. So these are small tidbits which we are doing. Now this is the new technique of abdominal hysterectomy I devised. I didn't have a retractor in my area, so what I did, I thought let us find a new technique of doing. So I developed a new technique, 3 stitches on right, 3 on left, and you can do hysterectomy without any problem. No blood transfusion is needed and all those things. This is surgery in sub-zero temperature. What happens to the hands of the surgeon? What happens to the patient? What happens to the instruments? 2 things only do not freeze. Gloves also freeze. Only thing, 2 things. 1, whiskey does not freeze at -20, and 2, ACD Syrah does not freeze. I ask people in the world who manufactures what is the freezing point. Even French people do not know, and even other people who are manufacturing this thing, they do not know. But this is 2 things don't freeze. That's everything freezes. Now this is another thing, simple thing. Betadine we are using. I thought why to do. I learned it from here. Just an idea I got that why not to use this हल्दी जो आपके घर में है, 10% हल्दी यूज करिए, बीटाडीन की जगह फ्री कास्ट है, कोई प्रॉब्लम नहीं है. कार्बोहाइड्रेट पार्ट निकाल दीजिए और उसके बाद यूज करिए. आई डन hundreds of patients, no problem, no complication, everything is free. Now this is called Sharma Sana yellow patient. Now this is a question for you also. Patient coming in OPD, see tomorrow or today. Patient coming in OPD, he is either anemic or jaundice if he is wearing yellow clothes. Now why do they come wear yellow clothes when there are anemic 6 gram, 8 gram hemoglobin, and they are using Villuka? What is the psych behind it? I do not know. I am putting this question to you. Please try to find it today, tomorrow, OPD. Patient wearing yellow clothes, he or she is either anemic or jaundice. This is known as Sharma's sign of yellow patient. Here are other ladies, see, newly married ladies still wearing yellow clothes, 6 gram hemoglobin. Now, another thing I have found that you do physiological phenomena. All sphincters are physiologically given to you. Delivery is also physiological phenomena. So why to cut the muscle? Muscle is so good. Nature has not given such a wrong thing. So what happens when you are difficult in delivery? Don't do episiotomy. This I named as skin episiotomy. Cut only the skin on this side or that side. Don't cut the muscle. Muscle nurse cannot suture. Muscle surgeon has to suture. Gynecologist has to suture. So you do only skin episiotomy and you will deliver normally, no problem. So this is called, I named it as skin episiotomy. Now here is another thing. I don't go detail because people oppose it, but there is a sex determination was a very curiosity from the जब से इंसान बना तब से क्यूरियोसिटी है. तो क्यूरियोसिटी के लिए बहुत लोगों ने टेक्निक निकाल दी है और ये भी एक हजारों साल पहला टेक्निक हमने निकाल के दिखाया लोगों को. अपने घर में हर लेडी अपने घर में कर सकती है, नो प्रॉब्लम. नाउ दिस इज अनदर पेशेंट which I operated in 92, left lung, middle lobe, hydrated cyst, and these were the patient is still 9 and my discharge slip is also she is returning today because I tell my patient keep this discharge slip as a 100 रुपए का नोट रखो संभाल के, कभी भी आपको काम आ सकता है. Another child right hydrated cyst I removed and people were surprised कि ये गाँव में कैसे कैसे हार्ट और लंग की सर्जरी कैसे, हार्ट सर्जरी भी demonstrated, live demonstration, people who have attended they have also seen that. Now this is overhauling a patient. A new term I have used, overhauling a patient. कि you do 4-5 operation एक में ही कर दो. And the first operation I did in the world was the hysterectomy with cholecystectomy with resection and ileotransverse colostomy. This was the first operation I did in the world, and now people can do it with these new techniques. You can always do it. You can always do multiple surgeries. So many cases. Here they hysterectomy कर दिया, ऊपर से epigastric hernia also repair कर दिया simultaneously. Now here is another patient. First patient I did was this, which I told you. So another patient, hysterectomy with cholecystectomy with uterolithotomy. All the three in one. This is the patient which I did. Another thing, hanging lipomas. You can see bilateral inguinal hernia operated. Bilateral inguinal hernia I routinely operate every time. Another problem, sacrococcygeal teratoma. You can see this. Another hysterectomy with pyloidectomy. Again you can see hysterectomy with pyloidectomy. This is TURP with right herniorrhaphy. TURP done, उसके बाद herniorrhaphy भी साथ में कर दो, hernia भी है तो ठीक है, कोई परेशानी नहीं है, you will no problem. TURP with suprapubic cystolectomy. Patient having open bronchopleural fistula. Patient came with bronchopleural fistula and these two operations were done simultaneously. There was no problem. और अखबार से ढक के रखा था fistula को. Ovarian cyst with small intestine adenoma, again done simultaneously. Now here is a cleft lip. अब cleft lip is a congenital condition, I do not know. But माँ को, बाप को, बच्चे को, तीनों को था. तो I repaired all the three. ये देखिए बच्चा भी, बड़े भी और ये भी सारा सबको एक ही बार में रिपेयर कर दिया when they came to us. Then this is another strange thing. कि left young lady of 14 years with hernia on the left side. Strangulated hernia, I operated. Once I went inside, I found that the appendix, how do you expect appendix on the left side? So I removed the appendix. Then I saw there is something goalmole. So dekha it was right ovary. It was replaced and left ovary which was strangulated, I removed. So this is how, and her kidney was in the pelvis. It had not gone up. Now this is another multiple surgeries again. You see, I didn't have a wire for doing this leg veins. So scooter gear wire I used. For removing the scooter gear wire, you can easily use, there is no problem for stripping the veins. Then mesh, center there is a mesh you see. Mesh I used, as you know, everybody knows this mosquito net we have used. And this is hernia. Hernia with both these legs and plus hernia. This I operated simultaneously in this patient. Now this is multiple hydrated cyst, both lobes of liver and spleen. So what to do? In single incision, I did splenectomy also. Next is splenectomy also I did same patient. Midline incision I gave and splenectomy along with right hydrated cysts also, liver cysts also. This is, you can see the splenectomy done, multiple cysts. But what I found, simple technique. You did not need green clothes. We were taught green, use green clothes. No, I don't use white clothes. Because first simple thing is you push, you see the hydrated cyst where it is, push the needle there, aspirate all the things, 10% नॉर्मल सलाइन या फॉर्मेलिन जो भी आप डालना चाहते हैं उसी नीडल से डाल दीजिए और उसके बाद यू ऑपरेट, यू आर नो प्रॉब्लम, एवरीथिंग विल बी फाइन. Now this is third degree vaginal tear as well as hemorrhoidectomy. So vaginal tear I repaired, then I said इसको piles भी हैं तो why not ये भी क्यों ना कर दिया एक ही टाइम में, तो piles भी कर दिया. तो ऐसे multiple surgery you should also do, patient के benefit के लिए होते हैं. तो we have developed all these things. Now generally this is taught all over the world कि bile जो है gallbladder liver में बनता है, नीचे आता है और नीचे आगे राइट लेफ्ट हेपेटिक से सिस्टिक डक्ट से यहाँ जाता है, ऊपर जाता है और उसके बाद कंसंट्रेट हो गए फिर थ्रू कोलेसिस्टोकाइनेट. हमने कहा ये गलत है. अगर ये बात जो आप बोल रहे हैं दुनिया में जो पढ़ा रहे हैं अगर वो ठीक है तो स्टोन कभी नहीं बनना चाहिए, गॉल ब्लैडर 2 बार कंट्रैक्ट होगा. लेकिन ये जो बाइल है सॉरी ये जो बाइल है ये अलग है. दिस बाइल इज सेपरेट और इसके कंपोजिशन अलग है. ये मैंने कंपैरेटिव स्टडी करके इस सॉरी ये पीछे जाना भाई जरा. हाँ, तो ये बाकी सर्जन्स को डेमोन्स्ट्रेशन कर दिया कि जो मैं कहता हूं ठीक है कि नहीं. आई कैन डेमोन्स्ट्रेट ऑन दी टेबल कि अरे भाई सब सर्जन को बुलाया और हमने कहा देखो ये दोनों बाइल्स में क्या क्या फर्क है ये आप देख सकते हैं. ये था तो ये करके दिखा दिया सब सर्जन्स. ये देखिए सब सर्जन खड़े हैं, दे आर सीइंग कि जो मैं कह रहा हूं गॉल ब्लैडर की फिजियोलॉजी को जो गलत पढ़ा रहे हैं दुनिया में वो सही है. ये है गॉल ब्लैडर. दिस इज a 6.2 inches gall bladder with 314 stones and the name written there is my name is written with those stones. Dr. K.C. Sharma is written with those stones, 314 stone which we had removed from this patient. The lady is here before you, she is fine. Now this is largest gallbladder capacity is under 132 cc I removed, and this is another technique which I told about gallbladder hydrated cyst out removed. Ultrasonography. Now ultrasonography I got two things only. I'll quickly tell you. One, the lady is virgin or not. Do an abdominal ultrasonography only and you will know whether the lady is virgin or not. One, person is impotent or not. You do abdominal ultrasonography and you know that person is impotent or not. So I new techniques I got this. You can do it even tomorrow. Tell I can demonstrate in ultrasonography anybody that this is some observations on ultrasonography. One thing more, that in vertex presentation, mind it, in vertex presentation, the male child has puts his spinal left and otherwise.
Sharma sir, you have to be very quick. You're of the time.
I'm just finishing, sir. Just finishing. So this is how it is. And now, simple thing, how to pretend the child is intelligent or not in the uterine life. So this is two signs I have put in. This is called Om sign or Trishul sign. If both the signs are present, child will be exceptionally believed. This is ultrasonography observations. Sharma's Trishul sign and this. Just now these are India's 5 gifts to the world, which you already know. I need not go into detail. Now simple thing, 27 लाख करोड़ की दवाई स्लीपिंग पिल्स बिकती हैं दुनिया में साल में, और हमने नया टेक्निक निकाल दिया जो 2.5 मिनट में सिखा देता हूं और 12 मिनट में आपको नींद आ जाएगी. दिस इज सिंपल टेक्निक विच आई बिल्ट एंड नाउ ट्रेनिंग पीपल ऑल ओवर द वर्ल्ड एंड पीपल आर वेरी हैप्पी. दिस इज न्यू ड्रग आई हैव फाउंड, टेपवर्मिन. In Ladakh area you get tapeworms, and two new types of tapeworms are described, black tapeworm and tapeworm with stripes, which are not known to the world till date. This is how Dr. Khalid Feroz has made this, so I copied it from him, that how rural doctor की problem क्या होती है. These are the innovations which I did many years before and I was honored for that. This in your
Dr. Sharma, please try to finish it now.
Right sir, खत्म हो गया sir. These are the tapeworm, medicine, parasitology, dermatology, arthropharmacology, extrapulmonary tuberculosis in Jammu and Kashmir in a patient. Extrapulmonary tuberculosis, see, you can see it. Again, these are the few rare things. Alopecia का treatment हमने निकाला हुआ है. फिर ये गुच्छी निकाली हुई है, नहीं है. ये है समझोन एप्पल निकाला है. ये है, ये एप्पल देख लीजिए आप. ये न्यू स्लोगन है. शर्मा साल मिक्सचर है. सो मेनी थिंग एग्रीकल्चर में सजेशन फॉर इंटरनेशनल कॉन्फ्रेंस में आपको ये सब बता देता हूँ. एक म्यूजियम खोलिए, मैं सबसे कह रहा हूँ यहाँ म्यूजियम बनाइए, जो क्रिएटिव लोग उनका म्यूजियम बनाइए और क्रिएट गुड इनोवेशंस के लिए रखिए इन लोगों को लिए. न्यू स्लोगन बुक्स जो हमने लिखी है, सारी 11 बुक्स लिखी हैं, ये लिस्ट है उनकी बुक्स की. दीज आर द फ्यू ऑफ द बुक्स ड्यूली ऑनर्ड बाय प्रेसिडेंट ऑफ इंडिया. आई वाज ड्यूली complimented by President of India. And Unknown Innovators and Discoverers book is also there, Unknown Innovators. 9 books released by one of the book released by Governor. Again, awards, honors, these all over the world are available. But आपको प्रॉब्लम्स जरूर मैं बताऊंगा कि ये है कि ये आप सुन लीजिए ध्यान से, एक से एक आधा मिनट और लग गया, कि ये आपको एक ट्रेमर आता है बॉडी में. हर रिफ्लेक्स का कोई मतलब होता है, लेकिन इस रिफ्लेक्स का क्या मतलब है मुझे पता नहीं अभी तक. आई विल रिक्वेस्ट यू, आप देखिए कि ये अराइज का, ये देखिए, ये या पीछे से अराइज होता है और सडनली ऐसे एक जर्क आती है सबको. इसका मतलब क्या? आई डू नॉट नो, आई एम पुटिंग दिस प्रॉब्लम टू यू, प्लीज ट्राई टू सॉल्व इट इफ इट इज देयर. टिप्स ऑफ रूरल सर्जरी ये तो है ही है. ढूंढोगे अगर तो ही मिलेंगे रास्ते, ढूंढोगे अगर तो ही मिलेंगे रास्ते. मंजिलों की फितरत है, वो चलकर नहीं आती. Your talent is your God's gift given to you, and optimum utilization of your talent is your gift back to God. This is how all surgeons of the history I pray before, and then with prayers I do my work. I quote Einstein again, 100 times every day I remind myself that my inner and outer life is made by labor of others, people living or dead. I must exert myself to return the same as I have received and still receiving. Thank you very much.
Thank you, Dr. Sharma, for a nice talk
Thank you.
on innovations. You are really innovative.
Thank you, sir. For a time ज़्यादा ले लिया, but I'm sorry for that.
Okay. Now I would like to request Dr. Abid Hussain Wani. He's a consultant GMC Baramulla. He'll be talking in the beginning of surgery of corridor surgery in GMC Baramulla. You will have just 8 minutes to finish your talk and 2 minutes for discussion. Thank you.
यहीं से करना है.
I need 10
Any
minutes.
pointer? No.
I need 10 minutes.
No.
अच्छा, और
So I can like do page up and page down.
नहीं 10 मिनट
अच्छा,
10
इससे.
10 minutes.
ठीक है.
Yeah.
No need.
मतलब 10 मिनट.
Assalamu alaikum and a very good morning to all of you. I come here from GMC Baramulla. Greetings from GMC Baramulla to all the audience, including my teachers and the chair, which are all my teachers. So I will be deliberating my talk on the journey of colorectal surgery in GMC Baramulla, initial hiccups. As you know, colorectal cancer is a preventable disease and is the world's 3rd most common cancer. As per Globocon 2020 report, it accounts for around 10% of all cancers and 9.4% cancer-related mortalities throughout the world. In India, colorectal cancer represents 2% of all cancers. It is the 2nd most common cancer in Kashmir. Colorectal cancer can occur in young adults and teenagers, but the majority of colorectal cancers occur in people older than 50. For colon cancer, the average age at the time of diagnosis is 68 for men, and for women it is 72. For rectal cancers, it's age 63 for both men and women. Comparing the incidence in Kashmir, gastric cancer comes at the top, followed by colorectal cancer. Then we have lung cancer, head and neck carcinoma, and breast carcinoma following the track. About symptoms, usually early colon cancer usually has no symptoms, and advanced disease can present with abdominal pain, change in bowel frequency, bleeding per rectum, tenesmus, weight loss, and anemia. The evaluation and diagnostics baseline investigations are to be done in every patient: chest X-ray, digital rectal examination, ultrasound abdomen, colonoscopy, CT abdomen and pelvis, MRI pelvis, especially for rectal cases, CA levels, and PET scan usually in follow-up. Coming to the management, multidisciplinary care remains at the core of the treating colorectal cancers. It relies upon an effective multidisciplinary network of surgical, medical, and radiation oncologists and palliative care physicians. All new cases should ideally be discussed at the tumor board and at multidisciplinary meetings. The various treatment options available are: for operable disease, primary surgery with or without adjuvant chemotherapy; for locally advanced disease, in which primary curative resection is unlikely, consider pre-op chemo. In isolated metastatic disease, consider resection of primary disease followed by metastectomy with or without neoadjuvant and or adjuvant chemotherapy. For widespread metastatic disease, palliative chemotherapy and supportive care is all that's needed. The surgical armamentarium has evolved from open procedures, then lab procedures, and now is the time of robotic procedures. But there is a considerable learning curve. So, we as Department of General Surgery GMC Baramulla start our journey in 2019. And more often than not, when we embark upon a new journey, we have no idea as to where we would reach and what would that path be like. It was a challenging task ahead, but believe you can and you are already halfway there. With a high incidence of colonic and rectal cancers in our valley and already burdened healthcare facilities in tertiary care hospitals like SIKIMS and SMHs, the Department of General Surgery Government Medical College Baramulla envisioned at its inception the need to start colorectal cancer surgeries for the benefit of local populace. The task was challenging though. Then came COVID-19. Our data is a small data. It comprises of right hemicolectomy 5 cases in which we did 4 open and 1 was lab assisted. Left hemicolectomy 8 cases, 5 were open and 3 were lab assisted. Low anterior resection 3 cases, 2 were open and 1 was lab assisted. 2 APRs and 2 transverse loop colostomies. During the post-op care, in the absence of an ICU, all our patients are monitored in post-op wards by our consultants and senior residents. Several complications were encountered in the post-op period, which are tabulated in the next slide. We had an anastomotic leak in 1 patient of hemicolectomy, which was managed conservatively. We had an addition obstruction, 1 patient managed conservatively. DVT in 2 patients, 1 was managed conservatively, 1 was referred to SIKIMS for ICU care. And wound infection 4 patients, all were managed conservatively. Now all patients stage 2 and stage 3 were subject to adjuvant chemotherapy in our oncology department. We follow our post-op patients on the standard guidelines with regard to post-op colonoscopies, CA levels and CT scans wherever indicated. We lack a radiotherapy unit in our hospital. We are moving slowly forwards but steadily. We performed our maiden laparoscopic assisted low anterior resection on a patient with an early rectal carcinoma in March this year. On histopathological examination, both proximal and distal margins were free of tumor. Patient oncology department and on our follow-up also. This is the intra-op picture and the resected specimen of the same patient. The pathological staging came P-T2N0MX. The limitations that we face, we don't have an ICU. As you know, colorectal surgeries are major surgical procedures, so patient may need a high dependency unit in the post-op period. Non-operational ICU is a limitation in our endeavor to further explore this path. We have to choose our cases selectively. Lack of infrastructure. We have only 1 operating room available for us for both elective and emergency surgeries. No separate emergency operating table. It seriously limits our operating capacity. We are a small department without postgraduates. Postgraduates are the backbone of any department, so their absence hinders progression. We hope to get DNB approval this year. Our blood center has recently been upgraded to provide blood components. We don't have any dedicated stomach care nurses, no tumor board for proper decision making, and we maintain a good liaison with oncology department, but lack of manpower hinders multidisciplinary approach. Thank you.
Thank you, Dr. Abid. You are doing a commendable job despite so many limitations. Any question? We have some time, 1 or 2 questions.
Sir.
He said no, we don't.
Sir, as I said, we don't have a functional tumor board till now, but we have a medical oncology unit who can give chemotherapy, so we are discussing. Definitely, sir. We did 3. Right, sir. We did only 3 cases, rectal tumors, early cases, discussed with them. They didn't need any neo-adjuvant, so we operated them. We don't have MRI facilities in. We send them to Srinagar, definitely, sir. Yeah, yes, sir. Right, sir. Definitely, sir.
You have a gastroenterologist there, you are doing routine this colonoscopy office?
Yes, sir. We have a very good gastroenterology department here.
Yes.
We have 4 or 5 consultants.
Very
so
good.
we are doing everything there.
Thank you very much.
Thanks a lot, sir.
Now, before calling the third speaker, I would like to congratulate the Department of Surgery headed by Professor Mufti Mahmood, Professor Iqbal Salim and all the colleagues of the Department of Surgery for organizing this beautiful conference. I will call upon Dr. Nazir Wani, who is the Professor GMC Anantnag, Department of Surgery. He will have a lecture on IPOM Plus experience from GMC Anantnag. Professor Nazir Saab. This is also a very starting college, all the peripheral colleges. So we have little experience, we have lot of limitations. So this is, I think, appreciable that we have started all these procedures.
Good morning, respected chairpersons, my dear colleagues. First of all, I thank organizers for giving me the opportunity. As Dr. Orbit said, our college has also conceived in 2019. I bring greetings from my college. As you know, that ventral hernias are basically a defect in the fascia of anterior abdominal wall without a bulge. They can be asymptomatic or they can produce symptoms. They can be giant and we have various complications. So the complications are as good as they can have loss of domain. So we need to manage these patients. I will not go into details of EHS classification. You know that these patients can be classified as midline, lateral. Similarly, we have now why IPOM Plus I have selected that. As far as literature is concerned, in laparoscopy, first concept was the tension free repair. You don't need to suture that because that causes problems. But theoretically, we have seen that there are advantages, and literature is supporting that 6 to 10 per centimeter defect should be closed with suture. That restores the abdominal muscles to physiological position. Mesh is in contact with the greater surface if we close it and overlap for incorporation. There is decreased recurrence rate has been proved now. They reduced bulge mesh into the hernia. Sometimes if it's a big defect, you put a mesh, it can bulge into the hernial sac. So bulging causes poor cosmetic results. These all things are the theoretical advantages. But as we know that we are going through an era that we want tension-free repair, we thought that this may cause problems. There are some studies which show that there is pain threshold is more if we close the suture. But as far as studies are concerned, like a series of Plano below, 5% long-term pain, and we have seen that although operating time is more, but the results are very good and recurrence rate is very low. Now discussing our case capsule which I have selected for a video is 78-year-old female which we operated with known rheumatoid arthritis with deformities. She had undergone open cholecystectomy in 2008, 6 into 7 centimeter subchondral incision hernia was there. She had a postprandial discomfort, pain and cosmetic concern. CECT documented 7 to 6.5 centimeter defect with stomach and gut loops as the contents. Few cardiac issues were with their hypertension and investigated her within normal limits, and our anesthesia team prepared her and we did IPOM Plus. Could you please run the video?
Main complete.
No, that's been done.
189 canal.
Sure.
189 canal. At the most, 10 buildings.
So we conventionally put 3 ports, and this is what we saw inside is that there was a big defect and all omentum was tucked in and stomach, this small gut was hanging from the, as usual we start from the periphery away and we go as close to peritoneum as possible so to avoid any gut injury. So we will not go into the details of the section. This is how we go for. This was the, here you could see stomach hanging, which we have to separate. We have to be very cautious that you do use what rightly said, you should cold and resources, but we were lucky enough to that gut was a little bit lower down and there was space in between, so we use it harmonic. So these were the contacts. Ideally you use an assistant to push it down and then you separate the adhesions. It was stuck up momentum with the this sac. Of course you have to maintain hemostasis while the momentum is hanging because you may miss some bleeders. This is the final adhesion, stuck up momentum. And then finally you clear the space around. This was one more thing, that right lever was also stuck up and it was adherent to the anterior abdominal wall. So we have to separate, we have to make a space for putting the mesh all around. So this whole right upper lever was stuck up. So you get all the adhesions and all the organs down, and finally you start suturing. We use a V-lock, there is routinely V-lock for endosuturing, and you reduce the pressure to so that you can approximate nightly. We keep a pressure of 8 millimeters, and finally you close the defect. And in this patient we have put a composite mesh. You get a central structure, this, and central suture to orient the mesh, and this is how we did outer and inner crowning, and this is the final picture. Next. So, show you our experience in GMC Anantnag. We have so far, continue. This is the 7th post-op day of the patient. We have, for last 2.5 years, done almost 91 cases of hernia were operated in our hospital, out of which 71 were primary hernias and 20 were incisional hernias. Of course, it is a single surgeon experience that we have done around 20 lap hernia surgeries, and rest of the surgeries have been done, 71 have been done. 91 surgeries total, 71 open methods and 20 by laparoscopic surgery, and primary hernias 5 and hernia 15. So we could see that most of the patients were in the age group 40 to 80, and this defect was gut contents were omentum, small gut, large gut, and most of the patients had omentum as contents. And these are the data. We are seeing hospital stay was very short. We could see that complications were a failed access with conversion in one patient where we did open mesh hernioplasty, hemorrhage in 2 patients where it was because of the tacker hit the superior epigastric vessel, which was taken care of by port closure needle sutures. Small gut injury in 1 patient which we missed, and 3rd post-op the patient with peritonitis. Then we opened the patient again, we declosed the enterotomy and we took out the mesh. Seroma in 5 patients, port site infection was not noted in any patient, and recurrence rate till date we don't have any recurrence rate. Conclusion is that left ventricle is a safe and excellent alternative to open ventral hernia repair for management of abdominal hernias. Advantages include shorter hospital stay and brief convalescence. High risk of bowel injury is there in laparoscopic hernia than open hernias, but less incidence of surgical site infections. Quality of life and patient satisfaction better with laparoscopic mesh repair than open ventral hernia repair. IPOM Plus has a better outcome and lesser recurrence rate, though suturing technique is tedious and has a long learning curve, and surgeon has to be very much experienced. Thank you very much.
Thank you, Dr. Nazir, for this excellent talk and the video very nicely presented. I really compliment you for starting this type of surgery in GMC Anantnag, where we have limitations, but still you are doing wonderful job. Thank you very much. Thank you.
Dr. Naveed, am I audible?
Yes, please.
What's the machine you are using?
We are using combined mesh, sir. We have a supply in the hospital.
The laparoscopic tower what you are using,
Yes?
Machine.
Machine.
Machine, we have a striker.
Striker.
Striker, a very good third generation striker machine.
Equipment.
We have very nice equipment and we are lucky to have Ayushman Bharat with all packages and meshes available, and definitely that is having poor patients.
It is available.
Dr. Ji, how do you select whether to go for IPOM or IPOM plus?
This is again, I told you as per literature, if his size is more than 6 centimeters, we usually close the defect. Less than 6, 4, 5 centimeters, most of our series were 4 to 5 centimeters, where we just do IPOM only. We don't
You
do
always use V-lock or something else
We
also?
use VLOC, we have VLOC available.
Thank you.
You must have been selective in selecting the cases.
Yes, sir, because in our place we don't have ICU facility just like Baramulla, we always, our anesthesia is not that much packed up, so definitely we select
Single
patients.
experience.
Yes, sir, we do optimization of the patients.
It's an excellent job.
Thank you very much.
Thank you, sir, thank you, sir.
Now I call upon Dr. Ajaz Rathur. Dr. Ajaz has been my house surgeon. I know him since my house job. He has done his PG with me. He has my registrar also. And then he was selected as consultant in JVC Lemina. And now has come to the stage of professor. I compliment him, congratulate him about that.
Thank you, sir.
He is talking about the acquired diaphragmatic hernias, his level management.
Assalamu alaikum, very good morning to all of you. For me, it is always a pleasure to deliver a talk at this prestigious institution, which has been my alma mater at for undergraduate and postgraduate level. And a gratitude to my teachers sitting on the dais, Professor Mumtazuddin, nevertheless Professor Salur Saab, as he said, I know I have long association with him since 1991 when I was a house surgeon, and then joined as a postgraduate and post-PG assistant surgeon at the registrar with him. A nice teacher, sir. It is only because of your good wishes and the teaching and training that I am here what I am. Thank you so much. So, beta, upload. Where is the presentation? Presentation. Huh.
Timer पे बंद. Timer पे बंद. Timer पे.
I am going to talk about our experience at Sikkim Medical College. Can you keep it on here? It's not going. At Sikkim Medical College, Bemina, a series of 5 patients of diaphragmatic hernia, which was the first case was done in 2016 March, and then the last case we did just few months back in February 2023. Now, as we all know, acquired hernia is a rent in the diaphragm which allows the herniation of abdominal viscera into the thoracic cavity. And a great tribute to Sir Ambrose Paré, who was a French barber surgeon, one of the fathers of surgery, a forensic pathologist, and a warfare surgeon, who described the first diaphragmatic hernia in 1579, a mason who was wounded in the middle of the diaphragm, and then on opening the abdomen, he could not find the stomach there, and found a small rent of the size of the thumb, and stomach had moved to the chest. Again, second case he describes was a patient, a French artillery captain, who was had a gunshot injury. Though he survived at the first instance, then after 8 months he died because of the gangrene of the colon. Pathophysiology I will be discussing while demonstrating the video. Now the left side is more common, 70 to 80%. Right side is 10 to 20%, and bilateral is 1 to 2%. Now, if you review the literature, the first repair was done by Riolfi in 1886. And then laparoscopic repair by Admet in 1984. If we go to the literature, and from the US we find 4 persons out of 5 are men. But in our city we had only 1 male and four were females. The penetrating injury is more common in the cities from US because because of the crime and all penetrating injuries, and they are more there. So in our series, we had all the blunt trauma cases, and rupture size is usually more than 5 centimeters. Now, going to the profile of the patients in our institution, we had the first very case, 55-year-old female, and then we had only one male, 46 years old. The mortality and morbidity was nil in the group. Hospital stay was 3 days average in 3 patients, and 2 days was for 4 patients. It was for 2 patients, 2 days, wrong here. So conversion to open was in none, all were laparoscopically managed. Now, the modality of treatment, diagnosis is first the X-ray chest, which is normal in 50%, can be normal, maybe there is elevated diaphragm and gas bubble we can find. And if we find a Rayleigh's tube in the thoracic cavity, that is pathognomic. Now, ultrasound is, as you know, reliable and cost-effective and available everywhere. It also has a sensitivity of 82%. Then multi-detector CT is the investigation of choice, and diagnostic laparoscopy is the gold standard. The treatment options available with us are the traditional thoracotomy, open or laparotomy, but it has now been replaced by less invasive procedures, laparoscopy and thoracoscopy. Chronic hernias are difficult to repair than the acute ones because of the adhesions and retract, because the diaphragm gets retracted. But the laparoscopy definitely has the advantage. Beside the other general advantages we have, the delineation is clear anatomy and adequate working space and early recovery. Now, lot of debate has been there whether you do 1 layer or 2 layer repair, or whether you interrupt it or continuous sutures, but it has been proved that one is superior to none. They have the equal results. However, the mesh repair should be considered only when you are not able to close the defect primarily, and there are some studies which suggest that it should not be considered as a standard method of repair. A word of caution that mortality rate from the elective repair is low, but if the gangrene gut is there, the mortality is very high, 80%. Therefore, to prevent the late serious complication of the diaphragmatic hernia, surgery is mandatory for late presentation of dramatic hernias. Diagnosis often missed, so high index of suspicion is very important. So we conclude here that laparoscopic repair of diaphragm is safe and effective modality of treatment. Laparoscopic repair helps in delineating the clear anatomy with adequate working space, early recovery besides the other advantages as I said. Traditional approach should be replaced by more safe and effective approach, and acute injuries, they are approached through abdomen and chronic through. This is the video. I am going to demonstrate the 4 videos which are on the left side of the diaphragm. This is the first case. We operated a female, 56-year-old on the left side. You can see the video. It was a nightmare for the surgeon because I was not experienced that time. It was the first case, and to my surprise, when I put the laparoscope in, the stomach was in the chest. Not only that, a big, huge splenomegaly was there. Can I have the pointer? Which had gone into the chest. So got a bit confused at that time how to tackle the problem. But as you know, patience pays always. So on that you can see a girl with the small gut in the diaphragm in the chest, and there were the 2 where there were adhesion on the left side, and we had a colon in the 4th case. What is the, yeah. So what we did in the first case, that just we elevated the head end, because you know there's always the tendency for the viscera to go in the chest because of the negative pressure in the chest and positive pressure in the abdomen. So just keep a sustained traction on the, I kept the sustained traction on the stomach. You can see the stomach is edematous. Pulling it will cause the avulsion. And if we would pull the spleen, you can see here how big spleen is there. It would cause the avulsion of the pedicle, and you know the after effects. So we gradually tried to give traction and got the spleen and stomach out and released the adhesion and did a primary repair with, in 2 patients we did use it, this stratifics, and then in 3 we used polypropylene thread. You can see here the spleen has been delivered here, and see the gut is trying to again go back because of the negative pressure in the chest. In the 4th patient, the colon was stuck up there. You can see the adhesions we are releasing with harmonic and then with monopolar diathermy. and this is the defect on that side. And so far, we did not have any recurrence, and we have the follow-up since 2016. So regarding the repair, we did all continuous in all the patients, continuous repair, no interruption was done, and a single layer repair we did in all the cases. So just going to the why the right side hernia is less common than the left, because the liver gives protection to the diaphragm on the right side, and number two, next video can I have? Number two, pleuroperitoneal canal, it closes earlier on the right side than the left side. So this is a patient of right diaphragmatic hernia. We can start the discussion also during the same time. So this patient had gangrene of the omentum. This patient had the gangrene of the omentum, and why it is on the mechanism of hernia, diaphragmatic hernia, is that normally there is the negative pressure in the chest, but when we take this deep breath, when we inspire, the diaphragm contracts and pressure, pleuroperitoneal pressure difference goes from 7 to 20, and during trauma it may reach up to 20. It may reach up to 100 or 200 centimeters of water and cause a disruption of the diaphragm at the anatomical sites. So you can see here the defect is being here delineated, and you can see the adhesions on the left side. The space is less because the liver is there. We have to take down the falciparum ligament, and then you can see the gangrenous omentum all fragile, and you have to be cautious, and no residual should remain. This patient was febrile for some days. We did not have the diagnosis. It was a diagnostic laparoscopy we did, and at the same time when we found the gangrene. This is the last year we have operated this patient, and patient is doing fine on the post-op follow-up. Just move it first bit. No, each go last. So we use a double loop polypropylene thread in this patient to close the defect. So we keep the post-op, we keep chest tube for 2 days. And two patients, the one is the first one, and this gangrene patient we kept for 4 days, and post-op recovery was good. Thank you.
I think it has been a nice experience of dealing with diaphragmatic hernias. These are difficult hernias to take care of. I think Dr. Atari will give some comments on it.
Yes, please.
Demonstration, and I think you have done quite a good number of cases. So, my complete explanation, when you close it with the fluid
Or stat fix. Yeah.
most of the time the diaphragm is very flimsy in these areas, and you have a cut through of this diaphragm. The suture tears out. So you have any experience of using any mesh or
No,
supplementing
sir.
it?
Yes. I will answer the question. It's a very good question. When the hernias become chronic, the edges retract. It becomes difficult, right, sir? So, but I didn't find any difficulty in getting the primary repair and getting the approximation of the edges. And second thing, which would limit my using mesh, government hospital, I have to use a dual mesh, which would cost 40,000. And then, including the cost of the tacker, 20,000, 60,000 would be the cost to the patient, and I don't think any patient in the government setup which I have operated would agree. And the literature I have quoted here also, that mesh is not required, and there's from National Institute of Health, which I just gave the reference, that you should avoid using mesh in these patients as far as possible. You can see the mesh is not considered a standard method of repair. This is the latest reference, December 2, 2022, by K. League et al. So whenever you find that your closure is under tension, you can use the mesh. But as for me, all the 4 patients I could do comfortably without any tension and without any cut through.
Any experience of excising this, you see, the flabby diaphragm?
No, sir. I didn't.
You have done only plication?
Plication.
Plication
Yeah,
suture.
completion, not plication.
Okay.
Basically, just I close the defect only.
Okay.
Not plication, we can say, because that we do for if you have redundant diaphragm and.
Okay, we have done few cases where we have excised the redundant
Yeah.
portion of the diaphragm by stapler or by
That
simple
we can
excision.
use in diaphragmatic
And
paralysis.
We
In
have, I
diaphragmatic
think,
paralysis, we have long.
whole of our department, we have a quite good number of cases.
Definitely,
Even Professor
definitely.
Iqbal sir has done few good number of cases,
Yeah.
and we have, I think, a very fair amount of
That is
experience.
done for not diaphragmatic hernia. That is done for when you have redundant diaphragm along paralysis. You usually post-phrenic, you have a
Right, you
redundant
can-
diaphragm.
you can
flat,
place. We have
you can
placed meshes
do
and I
plication.
think their results
Yeah.
were wonderful.
For that mesh will do better.
Thank you
Yeah,
so
that
much.
will. Thank you.
Thank you.
Dr. Iqbal, some comment from you? Just a comment, it's brief comment.
I think it's a wonderful experience, sir. I know how difficult it is to suture the diaphragm, but Professor Ijaz has done a very good job. Congratulations from me.
Thank you, sir.
Thank you, Dr. Ijaz.
I'm audible?
Yes, please.
It's a very common entity in our pediatric surgery
Yes.
practice.
Yeah, congenital diaphragmatic hernia definitely is.
And, just for the postgraduate, from the teaching point of view, so these patients come in respiratory distress. Hello? Are you? They come in respiratory distress, but by thinking that once you relieve this pressure on the medial sternum, the respiratory rate is going to become normal, the gases become normal, but it doesn't happen like that. They have a congenital hypoplastic lung. Even though if you remove this compression, still the saturation doesn't improve because the lung has not developed well. And second point is, pre-op CT, if you have done and you find that it's a compromised tissue inside, it is better to proceed for a thoracotomy than to pull lines. Because sometimes you have adhesions with the mediastinum. You'll be pulling the mediastinum into the bone. Then there's the problem. So, pushing in a controlled fashion is better than pulling it in a blind way. Thank you very much.
Thank you, Dr. Ijaz.
Thank you, sir. Thank you.
Thank you, Dr. Ijaz. Now I would like to request Dr. Manzoor Ahmed Dar Sahab to present his study outcome of multifaceted resection in colorectal cancer. Dr. Manzoor has served as the consultant at Srinagar Institute of Medical Science for almost a decade. Then somewhere in 2007 or 2008, he left for green pastures, and then he has returned 3 years back. Now he is serving doing a practice in the field. Dr. Manzoor.
Thank you.
He was recently appointed as a professor at Government College, Medical College Handwara, but he has not joined that place.
Thank you very much for your kind introduction. Assalamu alaikum. First of all, I would thank the organizing committee for giving me a chance to speak here, and at the same time congratulate them for a wonderful program which we saw for the last 2 days. My presentation actually was colorectal cancer, but it's too extensive. I won't be able to complete it. So I have brought for 6 minutes a very short, interesting, rare case. I hope you'll enjoy it. If I'm time short, just give me a couple of minutes extra. This is the place where I worked, King Abdullah Medical City at Shikir Hospital in Western Saudi Arabia. This is the first case which I am presenting. It's actually a 52-year-old male who was referred to me from a secondary hospital by another colleague, colorectal surgeon, and he had history of fistula in ano repair twice in the past. And after that, it recurred, and what they did a defunctional colostomy and told him that we'll do a proper repair. It might need a long-term treatment. In the meantime, this patient was not cooperative, so he insisted the surgeon to close his colostomy in spite of fistula being down there, still in a healing stage, and he referred it to me. When I saw him, he looked like a normal gentleman of average build, but when I looked at the perineum, it looked horrible. There are 2 fistulas there. There was a lot of scarring. When I put my finger in, I couldn't feel any. It looked like so all fibrous tissue, and there was no smooth mucosa. And when I asked him to squeeze, there was no muscular contraction. And he did give history of incontinence as well. So I tried to do a proctoscopy, but didn't get a good view. So I thought, let me get him his MRI and get his sigmoidoscopy done from the gastroenterology department.
So this was the picture on the sigmoidoscopy. There were multiple ulcers, there were fistulas as well, and things looked horrible. When I talked to the gastroenterologist who did that, he said, Manzoor, it looked like a Crohn's. But we have not been able to do his full colonoscopy because his bowel was not prepared. So let's do it. We have taken some superficial biopsies, and we'll see him with that, and we'll plan a full colonoscopy after bowel prep. So you can see these images clinically, and from these pictures, it looked like a Crohn's. So what his biopsy came back as non-specific inflammatory pathology. So they needed a deeper biopsy. So he was scheduled for colonoscopy, as I said. But on the day of colonoscopy, after he was having a bowel prep, he landed in emergency with acute abdomen, peritonitis, and we were called to see him. When I saw him, he was in a full-fledged peritonitis, tachycardic. So we thought this man, something has perforated. So while moving to the theater, we did an emergency CT in the emergency room and pushed some contrast in, and we found some contrast leak as well as some free air. So there was no other indication than to go in. So when I did a laparoscopy, what I found fecal peritonitis, and because of his previous colostomy closure and colostomy operation, there was a lot of adhesions in the left iliac fossa. There was a perforation, whole pelvis was frozen, and there was a perforation just at the site of fixed part of the bowel and the free part of the sigmoid colon. It was about 1 centimeter, which was causing contamination. And there were a lot of adhesions. So we didn't know what the pathology is. So at that time, there were few options. Either we had to externalize the perforation, bring it out, or do a proximal stoma, or the third option, which in this case, which was, what I did is, we disconnected his rectal sigmoid, brought it as an end colostomy, we took a full thickness biopsy, we gave an antigrade wash to his colon, to his rectal stump, and then tried to close this. We closed in 2 layers. Then we were waiting for the biopsy, and the patient went to ICU because he wasn't clinically stable. So we were waiting for the biopsy report, and it took them a while to get the biopsy report, and the pathologist said we had to consult our original lab. We found something different, and they did some special staining, and what they found is this is fungal hyphae, you can see in the center, and the phenomena which is producing is something called Splendor Hippoli phenomena. It is a phagocytosis of these fungal hyphae making a special cell. So they did some special staining as well, and they demonstrated that fungal hyphae. So we thought it's search what's the actual diagnosis, what's this fungus? They said this is basidobolomycosis, a very rare fungus. Starting this literature review, we found there were not many cases reported in the world, and we consulted our infection disease country department, and they said the best treatment for him is the antifungal treatment in addition to what he's getting antibiotics. So fluconazole and voriconazole was started, and this patient continued the follow-up. He came out of ICU after 2 weeks and was holding his vitals. But this is the CT and MRI which we did in the later stage. Whole pelvis was frozen. It's all fibrous tissue. And he was bent upon us, you close my colostomy or reverse. There was no point in doing that because there was nothing left down than the fibrous tissue. So he continues his antifungal treatment and was continuing with the follow-up. I'll tell you what happened to him at the later stage, and I'll show you a quick second case. This is a young man, how do you do that? 45, he landed in gastroenterology department with vague abdominal pain, loss of weight, and they had done a CT scan and they found huge mass in the right iliac fossa. Clinically, to them it looked, it's a tuberculosis, it's a lymphoma, although the bowel is not occluded completely, but you can see the still lumen, but the mass is quite extensive. So they did a colonoscopy and took a biopsy. These were the pictures from their colonoscopy. They found that something like horrible thing going on in the ascending colon and the cecum. And the biopsies again came non-specific. So ultimately, he landed up with us and we had to do a laparotomy. So I opened him up and found a huge phlegmon on the right side. There was no other finding except this mass. The liver was normal, no palpable lymph nodes, no ascites, no peritoneal mets. So we did a standard right hemiplectomy on him. This is the specimen. And next morning, I went to the pathology lab to see what actually it was. This is, you can see, the thickened bowel wall, whole cecum as well as appendix. When we cut the appendix, you can see the thickness of the wall of the appendix was almost 1 centimeter. When I divided the whole specimen, and you can see how thick fibrous reaction to the bowel was. It was about 4 centimeters thick on the other side, although the lumen was still patent. And on cutting it further, there is a remarkable picture you can see. There is a diseased area and the sharp demarcation of the normal colon beyond that. Very, very characteristic. So again, they took the deep biopsies, they processed it, and they came back. Again, this is the same kind of case which we had, bacillobacillomycosis. Here, all 22 lymph nodes were negative. So we did a search on that. Basically, this this belongs to a group called zygomycosis, and one of them is Bacillobacillus renararium, which is causing this disease. First of all, this fungus was isolated in the United States in soil, and it was found in the feces of amphibians and reptiles. And it was known to cause soft tissue infection in these animals, but not in humans. So first human case of bacillobacillomycosis was reported from Indonesia in form of skin nodules. We didn't have any report until late 60s of GI bacillobacillomycosis. There are simultaneously cases reported in Arizona as well as in the Middle East. In the Middle East, it was reported in Iraq, in Iran, in KSA, Saudi Arabia, about 11 cases, and also pediatric patients were also found about 27 pediatric cases with this disease, either involving right side of the colon or the left side of the colon. Usual presentation of this is either abdominal pain, mass, weight loss, fever. And the most common in the GIT is the colon and rectum affected, followed by small bowel and stomach. Diagnostic workup does not yield anything specific. All parameters are usually open unless you find a fungus and you culture it. That's very, very rare. And you have to differentiate. The differential diagnosis here usually comes a malignancy or a Crohn's disease when they come with the mass, or tuberculosis, or diverticulitis or a appendicular mass. Histology is very, very suggestive where it shows this fungal hyphae. That's the only diagnostic. And very rarely they are able to culture it from that tissue. Otherwise, they recommend you should culture this hyphae from the fresh biopsy specimen. So how do we treat it? Usually, they say if there are early lesions like ulcers and you detect it by endoscopy, treat them with voriconazole or etoconazole for 6 to 18 months, they will subside. Although some case reports have been, pediatric cases have been treated purely by antifungals. But when you present a mass like this, you need nothing short of a surgical resection, plus followed by antifungal therapy for about 6 to 8 months. Thank you very much.
I think your experience is much more important because the fungal cases we rarely see here.
No case has been reported so far from India yet.
These masses, we usually take malignant unless proved otherwise. So I've been lucky enough that they have been only mycosis. Any comments from audience? Yes. Professor Amar Javed.
Professor Manzoor, I think this is the right time and I should talk about it. We work together, it's beyond the subject, what is he discussing. Long back, 20 odd years back, and we lost him. And such an inquisitive person, such a fantastic surgeon. And I have a lot of respect for him. As an individual, as a human being, and he did some small research with me that time. And that formed the basis of Mirzi's further studies in world.
Yeah.
I think we recollected back once we published in 1998 or so in Australia and New Zealand Journal of Surgery. That formed the basis of a different classification, Cassendo's classification. The choledocoplasty we classified. Yeah. That sort of Manzoor was there. So, once he went to Middle East and he went to England and other things. In fact, he was instrumental in getting me awarded FRCS by the Edinburgh. Staying here in this part of the corridor of the world, where people think that we're backward. We're not backward. They are backward. We are mentally more alert. We wake up very early. I hope this presentation, what you presented, shows your inquisitiveness.
Thank you, Dr. Kumar. Thank you.
I congratulate you for this rare presentation.
Thank you.
And I hope best of luck for your future.
Thank you so much.
Thanks a lot.
Thank you, Dr. Kumar.
Any other comments from the audience?
No
comments. Thank you, Professor.
We'll call another.
Thank you.
Dr. Abdul Hamid Samoon, who is the Mr. Professor, Department of Surgery. He will have laparoscopic hepatocholecystectomy in OCH, the SMH's experience.
Respected Chairperson, dignitaries down there in the auditorium, my mentors, teachers, and dear friends. Very good morning to all of you. Today I will be presenting our experience about oriental cholangiohepatitis in the Department of Surgery, GMC Srinagar. So as all of you know, by definition, it's a recurrent bacterial cholangitis which occurs in association with intrahepatic biliary obstruction and intrahepatic bile pigment stones. So a lot of names has been given to this disease in the world, and this disease is more prevalent in the Southeast Asian region, and a lot of names like recurrent pyogenic cholangitis, Hong Kong disease, intrahepatic bile pigment stone disease, and biliary obstruction of the Chinese name has been given to this disease. So etiology, actually, etiology is not known. So there have been proposed etiologies. So most of them is the parasitic infestation. So these areas, the Southeast Asian regions, these are less developed. They are considered to be low socio-economic areas, and these parasitic infections are more common there. So what are the parasitic infestations? These are Colonorchis sinensis, Opisthochis species, Fasciola hepatica, and Ascariasis. And this Ascariasis involves around 25% of the population of the world. And as we see in this part of the world, in Kashmir, this is more common. So this disease is more commonly found over here. Second thing is bacterial infection. So it is controversial whether bacteria start the disease or then this disease is then complicated by the bacterial infections. So stasis is the third common proposed cause for this disease. Some people say that stasis is the first thing which leads to bacterial colonization and then the subsequent inflammation and fibrosis, whereas rest say that it's the reverse. Then how do these diseases manifest? So this oriental cholangiohepatitis manifests mostly as bouts of cholangitis. So patients have all the features of the Charcot triad, like pain in the right upper quadrant, then fever with or without rigors and chills, and then jaundice. So most of the presenting features include cholangitis in majority of the patients. Then patients can present to us as non-specific abdominal pain, and some patients present in emergency department as pancreatitis. While some of the patients, they go on with the disease and they then go for the treatment late in the course of the disease, and they may present with complications of the disease in the form of fulminant cholangitis, severe sepsis, then biliary cirrhosis, liver failure, portal hypertension, portal venous thrombosis, liver abscess, severe pancreatitis, and lastly cholangiocarcinomas. So imaging is very important in this disease. So the basic and the best imaging and the first imaging is the ultrasound. On ultrasound, we can find the common bile duct or the intrahepatic ducts. They are dilated. They may contain a lot of stones over there. And sometimes you may be able to find the abscesses there in the liver as well. So CT scan, again, it shows the dilated ducts. And sometimes it shows the constricted ducts as well. And you may have abrupt tapering of the peripheral ducts in this disease. Sometimes there is atrophy of a particular segment of the liver because of the obliteration of the duct as a whole, and your walls of these ducts will be enhanced because of the prolonged inflammation and fibrosis. So MRCP or the cholangiography is diagnosis of choice, and you can see whole of the ductal system there on the slide. So you may have a lot of stones over there. Stones may be of varying size. You may have multiple stones both in the common bile duct as well as the intrahepatic bile ducts. There may be, because of the progressive inflammation and fibrosis, there is a lot of the structuring of these ducts, and some ducts may get completely obliterated, and there may be some stones in the gallbladder as well. Again, ARCP is another investigation which is both therapeutic as well as diagnostic. So when you inject the dye, you can see a lot of filling defects there in the common bile duct, common hepatic duct, intrahepatic ducts. You may see these filling defects, a lot of stones over there. The ducts will be dilated, and you may see abscesses as well. Then how do we manage these cases of oriental cholangiohepatitis? So actually, when the patient comes in acute episode, we have to give IV fluids, we have to resuscitate the patient, we have to take care of the sepsis, we give good antibiotics, and we control the biliary sepsis. Then later on, what we have to do is, we have to decompress the ducts so that the infected bile comes out and the patient improves. So this drainage can be done endoscopically or can be done percutaneously as per the facilities available over there. So ERCP is the best thing. You can do a papillotomy and the pus can drain down, or if facilities are available, you can take out the stones and pass on a stent in the biliary system. Then definitive treatments is very important after this, because this is a chronic disease. Patients go on forming stones and they have repeated cholangitis. So some sort of definitive treatment has to be done, and definitive treatment can be done in the form of surgery on the bile ducts. So what is the definitive treatment? So if this disease is limited to a particular segment or a lobe, we can simply chop off that area and the patient can improve. If the disease is diffuse enough and the bile ducts are dilated, there are a lot of stones, what we can do is, we can go for biliary enteric anastomosis. And hepatocogenostomy is a procedure of choice in these patients, because you have dilated common hepatic or common bile duct, and you can easily make an anastomosis over there. Then if you cannot make this hepatocogenostomy because of some technical difficulties, you have other options as well. So you can go for choledocodidynostomy, and you can go for Roux-en-Y choledocojejunectomy or simply sphincteroplasty, depending upon the situation. So I'll be now showing you a video about laparoscopic hepatocogenostomy being done in our unit. So these patients may have gallbladder over there, or some patients may have undergone cholecystectomy earlier. So if gallbladder is already there, what we do is, you simply clip the this cystic artery and the cystic duct, and we use this gallbladder as a traction, so it helps us. Then after doing that, what we do is, we expose the common bile duct, we take the omentum, we take the peritoneum, from that we make a tunnel between the common hepatic artery and the bile duct, and posteriorly we have to separate this common bile duct from the portal vein. So because of repeated infections, most of the times there is a lot of fibrosis over there. So you have to be very cautious while separating the common bile duct from the portal vein posteriorly and the common hepatic artery medially. Then after making a plane, what we do is, we pass a sling behind the common bile duct and secure it with clips. After that, we lift this common bile duct and we start transection of the common bile, we start transection of the common bile duct, and we don't divide it completely. We keep few millimeters over there so that we can give enough washes, we can take out the stones from there. Then with the help of a suction device, you can see a lot of pus is drained, the stones which are there in the common bile duct proximally as well as distally, they are taken care of. So you can see how big these stones are there. So they are being taken out of the common bile duct. These stones are in the lower part of the bile duct, so clearance has to be done properly. So after this, what we do is we pass a suture over there in the uncut area of the CBD and use it as a sling, and then we finally divide the whole of this common bile duct. And after giving thorough washes, what we do is we just close the distal end completely. So this distal end is closed with the help of barbed sutures, and we use V-lock in this 3-0. So before closing, what I want to show is that we do intraoperative, we use a nephroscope because we don't have a choledocoscope to see the clearance of the ducts. After the closure of the distal stump, what we do is we go down there, we identify the duodenojejunal flexure, and we take the jejunum, make a hole there in the mesentery. Then after that, we pass a stapler, a blue load, and divide the jejunum. So this jejunal loop, the distal limb, which we are going to anastomose with the common hepatic duct, is brought behind the mesocolon, right on the right side of the middle colic artery, upwards, and then we start anastomosis. We start the anastomosis on the lateral aspect of the CBD on the right side. We do this anastomosis by a continuous method by using a barbed suture V-lock 30. Right now we are doing a study on this continuous closure by using a barbed suture in our department, which is known by the name of basis study, sir. So the posterior layer is sutured continuously there with the common hepatic duct. So the suturing should not be too tight or too loose. So this suture is continued towards the medial end, and then we can continue this suture on the anterior aspect. So you can see how thick the CBD is. So this is the anterior layer of the common hepatic duct, which is being sutured to the jejunum.
Can you run the video quick?
Yes, sir.
We are falling short of time.
So our experience at GMC Srinagar has been like that. We have done 52 cases of oriental cholangiohepatitis till now for last 18 months. We have done laparoscopic hepatocogenostomy in 50 cases, and 2 cases have been done by open method. Cholecystectomy has been done in 18 patients. Complication wise, we have found just 2 patients with bile leaks. 1 patient was managed conservatively, and 1 patient needed a re-exploration, and the anastomosis was refashioned. We had wound infection in 3 patients, which was managed conservatively. Thank you very much.
Thank you, Dr. Hamid. I would like to ask from you, what is the follow-up of these patients?
Sir, these patients are on regular follow-up with us. They have not developed subsequent stones. Their LFT has improved. We have done imaging like ultrasound, and we have not found any complications as of now, sir.
Do you expect some sort of a stricture at the site of?
So actually we make a bigger anastomosis. The ducts are quite dilated. So the rate of stricture formation will be gradual, if at all they will be there.
How will you access the stricture site?
Till now we have not got any case of, sir, cholangitis or with stricture.
It needs a long follow-up, little bit.
Yes, sir, definitely.
Maybe years together.
Definitely, sir.
So we have to see these patients whether they develop.
Definitely, sir. They are still on our follow-up, so we'll be seeing later on, sir.
Dr. Omar, whether Dr. Omar Javed sir, any comments regarding this?
Please,
thank you, sir.
Very good morning. Many congratulations for this series. Very well done cases. I think there is scope for a lot of work and research in this area. My concern is twofold, that ascariasis still will remain a problem even when you do a hepaticojejunostomy. You don't have problem of length of the common bile duct. So I don't find a reason to support hepaticojejunostomy as against a choledochoduodenostomy in these cases, because you lose the access loop to the common bile duct forever. In hepaticojejunostomy, you will not be able to go back into the common bile duct again. Whereas all the 18 cases where you had choledochoduodenostomy, you have that virtue remaining. So I would say that in your future cases, you can possibly try to see how you view these, and because length of the common bile duct is not an issue, you can go down at the lowermost end where the superior edge of the duodenum is there, and possibly disconnect at keeping the maximum length of the common bile duct there, and try to evolve a procedure for a choledochoduodenostomy, which gives you
choledochoduodenostomy, sir?
choledochoduodenostomy.
Duodenostomy, okay, sir.
Choledochoduodenostomy.
Okay, sir.
End to side, which you have done in 18 cases. Because the access loop to the common bile duct is gone, because the bowel will still have ascariasis, and the risk of going into and forming secondary stones in the common bile duct will still remain, but your access to the hepatic ducts would have gone. Thank you.
Thank you, sir.
I think this is a very correct observation which the senior doctor has mentioned, and of course, you see, the all thing what happens in, whatever you call it, so misnomer with world, OCH, hepatolithiasis, some other names too, nobody knows the etiology. We have been put hypotheses, this and that, and sometimes in these prevalent areas of ascariasis, we say that ascariasis is the cause. No, it's not like that. I have been a researcher in this for the last 25 years, especially surgical side of what I'm talking. Of course, we have a fantastic gastroenterology side, very good, strong foundation put by Professor Koru. Let me congratulate him today. Then we had Chaukat Saab and other things, which I was with him. You see, the thing is that the transmural infiltration of the inflammatory cells in this, understand what I'm saying, and the hyperplasia of the glandular epithelium, which produce the mucus in that. That is the site how it happens in the liver. Understand pathogenesis. There have been very good researchers like Yamada from Japan, he died. Dissolution of the stones came up. Although this is a disease of eastern part of the world, specifically we in Kashmir have it, and some part in southern India. One of the biggest problems is structure formation in this. As the senior professor put it across, if you are lucky enough not to have a structure, choledochoduodenostomy would be ideal. Yes, the problem is structure. And even those structures, they can intrahepatic structures as well as extrahepatic structures. We did a major series from this region in the world, which I think is becoming the foundation of certain research papers that got published, I don't remember now, about 20 years back or so, in World Journal of Surgery or HPP Surgery. 110 liver resections, left-sided resections. That was divided into two, structure and no structure. While we got a structure, we classified that. Intrahepatic structure, we could do resections, and we had a very good follow-up. Those all patients, most of them, 90% patients are still living. Isolated structures on the left side. They are the luckiest patients. If you have an extrahepatic component with that, then the story is different what the doctor is already talking. You do a choledochoduodenostomy associated. You got to keep them under longer follow-up. Especially ascariasis is prevalent here. You have to deworm them. They need minor amount of infection upstream going, and cascade gets going, and there's interleukin formation, and the cytokinin storm is there. They destroy the epithelium, and they finally heal up by structure formation. Right-sided structures, people have gone for right hepatic resections. It is condemned because they get into huge complication pool. They die. Liver transplantation, yes. Some of the people can get into liver transplant. There are very limited data available from Spain, even from East water. But again, the story is not that simple with them. What we have found, and in my own experience, and I think many postdoctoral students and postgraduate students, I have given this thesis. Babar was there, I think someone, but you did it on phrase, sorry. The other students, what we saw, you should put these patients, if you have low structure, as you have done, on urosurdicolic acid.
That's true, sir.
For 3-4 years. And there are multiple reports that dissolution of stones occur. And this is very important to deworm them. So if you don't have a structured disease, you are lucky. Do choledochoduodenostomy. because that becomes our access loop. If you have a structure upstairs in the bile duct, then do a hepatocoaguloscopy with an access loop. Do a Stigman's procedure or a Sitaram's procedure. Sitaram has his own problems in the lesser curve. Do it in the second part of the duodenum. Then the endoscopist, the multidisciplinary team takes over. It has to be a multidisciplinary team.
Obviously.
Transhepatic instrumentation, as John Turblanche from South Africa taught us. The J tube, U tubes, all those. You got to do it combined. It's a frustrating disease, especially if you see the youngsters. And these people get into cirrhosis, portal hypertension, and finally they land up into encephalopathies and they die of cholangitis and all this. Try to follow them. Try to follow them, you'll get the answers and you'll move ahead in the research. Thank you very much.
Thank you, sir, for kind words.
Thank you, Dr. Sami. Yeah, you will comment.
This is a wonderful, a topic, OCH. It's a, we had experience of doing hepaticojejunostomies over a period of 10 years. And what followed is, one of the patient had a stricture at, hepaticojejunostomy site. He was roaming here and there. And we were very fortunate that we had such a wonderful gastroenterology department now at AIG. So I had to refer this patient to Nageshwar Reddy sir. So what he did endoscopy and then he went up the loop and then he did a balloon dilatation. That patient is back and I hope it, it doesn't reoccurs there. So after that we came back to choledochoduodenostomy and we published our data from our GMC Srinagar in Indian Journal of Surgery, I think a few years back. Yeah. And I think choledochoduodenostomy is again a wonderful procedure, which has a wonderful results in these patients of OCH. Thank you so much, Dr. Hamid. It was a wonderful presentation.
Thank you very much.
Thank you, sir. It was really a dreadful disease. I remember and assisting Professor Umar, Professor Manzoor Saab, we used to operate them after 4 o'clock, and that too in emergency, because it's a very contaminating surgery, so we never used to do them in electives. So that would have been the situation that time. I would like to invite Professor M.R. Atri, sir, from the Department of Surgery, GMC Srinagar, for his talk on laparoscopic Whipple procedure, the final frontier. Thank you very much.
Good morning, chairpersons. Good morning, all the legions sitting in the front desk. I'll start by saying, वो उलझाते रहे मुझे लैब कोली और हर्नियाज में, मेरी मंजिल तो विपल्स थी. This is what I aspire for my younger colleagues, so that they come up with these good training, good skills, and come up with these procedures. Because laparoscopic pancreatoduodenectomy is here to stay. Its time is coming, and I think it is here to stay for another 10 years before robot comes in and grabs the situation. So we have a very humble beginning. Laparoscopy, as we all know, it's a gold standard for most of the things and preferred for bariatric, adrenal, spleen. So increasing utilization for liver resections and pancreatic surgeries have been added from over the last 10 years because of experience gained by the surgeons as well as the technology which has supported this experience. So as we know, our age-old Alan, old father Whipple, he was the person responsible for, popularizing this procedure called Whipple for over 100 years. Until the Gagner and Pomp, they came in 1994 to do first laparoscopic Whipples for chronic pancreatitis. And they were a bit discouraged because it took too much of time. It took 14 to 16 hours for them to complete a laparoscopic Whipples. So somehow they felt though this is a very tiring procedure, but slowly as the experience went ahead, so and keeping the benefit which the minimal access surgery brings along with this, we had all these benefits as associated with all other organs which are done minimal invasively. What are the drawbacks of pancreatoduodenectomy? So drawbacks are these. Learning curve. You have a very long learning curve to reach to the skill level where you can attempt and handle pancreas and all these multiple organs. It has an increasing operative time. You need a lot of stamina. You need multiple teams. You need a very good team. so that they back you up. Of course, cost. The cost has been, you see, taken care of by minimal invasiveness because ICU care has reduced after laparoscopic Whipple's surgery, so cost can be taken care of. And of course, all the risks of rebleed, pancreatic fistula and all those things. And finally, there is always a debate whether this is an oncologically acceptable procedure or it is not. The latest data from last 10 years, you see up to 206, there were only 194 laparoscopic pancreatic adenectomies done all over the world. In last 15 years, 12 to 15 years, this list has increased up to 25,000. Now the latest data is more than 25,000 laparoscopic Whipples has been done all over the world. So there is no question of that it is not oncologically safe, it's very safe and feasible. So why slow adoption in pancreas? Because it is a volume, because we know only 15% of the pancreatic malignancies are operable. Rest, it is all, you see, stage 3, stage 4, where we have to just, you see, do some sort of palliative procedure. It's a technically challenging because it's a dissection part is so much, then the reconstruction part is so much, length of stay. So again, these patients keep on, you see, in our wards for 2 weeks, 3 weeks, 10 days, 12 days. So it keeps our bed occupancy rate high. And the most challenging part is because it is associated with all the vessels, great vessels like portal vein, superior mesenteric vein, so and all celiac axis. And of course, it needs a very complex type of reconstruction. So we have a very humble beginning. We have done 2 cases in our GMC Srinagar. One case was done some two and a half years back. It was done for you see, CA head of pancreas, and it is under a follow-up. He's doing wonderful, and over a lot of last 2.5 years, he has you see, done exceptionally well. So then there is another case which we did 4 months back, and this patient is also doing very well. So this case 1 was, you see, in this 4 months back, we came across this 55 years old man who had a deepening jaundice. His CA19 level was elevated, and ERCP suggested some dilated CBD. So it was a grossly dilated CBD without any filling defect. It was stented, and a biopsy was taken, which proved to be periampullary adenocarcinoma. So CT scan was showing a dilated, again, IHBRs. There was a hyper enhancing lesion of 3.3 to 2.7 centimeter in pancreatic head close to the celiac artery. There were few lymph nodes in it, and you can see the biopsy which has come in the post-operative period. We have almost removed a good number of almost 37 lymph nodes, and 3 of them were positive. Our surgical operative time was almost 6 to 7 hours in this patient, and blood loss was 200 cc. We had an uneventful recovery, but we know it, as the volume will increase, the problems will arise. So hospital stay was 13 days, and this was the histopathology. It was T2 and 1 tumor, and lymph nodes were 3 positive out of 11 removed. Then we had a case 2. It's a you see, 50 years old male with no comorbidities. He presented with fever and right hypochondriac pain and a jaundice. He had a palpable lump in the right iliac fossa with ictus of 32. So again, this man was sent for ERCP, and his MRCP was showing a dilated CBD, main pancreatic duct, intrahepatic, you see, biliary radicals. Even he had a cholelithiasis and choledocholitis with a neoplastic lesion in the head of the pancreas. So he was, you see, sent for gastroenterology, who did you see, stenting, and he was optimized. His bilirubin was brought down, and you see, here we have again, you see, harvested some 37 lymph nodes in the second patient. So we as our experience has increased, the lymph node harvesting and the overall the time, operative time has come down. So in this second patient, we completed it in 6 hours. The blood loss was less, almost 150 cc. Hospital stay was, you see, almost 10 days. And you see, it was T3 and 1 adenocarcinoma. Bit of video. So this is the, you see, This is a short video. We have, you see, it for 8-hour surgery to be put back into 6 minutes. It's a very tricky thing. So I have just, you see, tried to, do it. After a thorough diagnostic laparoscopy, we peep into the lesser sac, and this is the cauterization of duodenum to see the operability of these lesions, and we cauterize it up to the IVC and the aorta, so that the tumor is not fixed, and the second and third part, and I find this is the most challenging part, is the duodenal dissection. Then once this is dissected, the pylorus is divided almost 2 centimeter beyond the pylorus. Then this is a dissection over the GDA. We remove the station 8 lymph nodes. Once the lymphadenectomy is done, we we dissect out the GDA from the hepatic artery and clip it with either Hemolock or suture or clips, whatever is available. And after dissecting the GDA off, then we take out all the pericholedochal lymph nodes and over the CBD up to porta hepatis and dissect out the CBD. Then we divide the CBD with scissors proximal to the cystic duct. And you can see that this was a quite dilated CBD with the thick walls. And next step is, of course, division of jejunum. The ligament of Treves is divided, and we divide the jejunum almost 14-15 centimeter beyond the DJ with the echelon or blue cauterise. And after this, after division of the jejunum, the next most important step is creation of a retropancreatic tunnel. This is the most important step in this whole surgery. So here the harmonic, your ligashore, they play great roles. You see, we have a minor vessels which directly go from pancreas to the superior mesenteric vein and the superior mesenteric artery. So our ligashore, which is available in our theater, it helps us a lot. So this retropancreatic tunnel is created from inferior margin of the pancreas to the superior border of the pancreas, taking care that the you don't cause any trauma to the portal vein, to the splenic vein. Once the retropancreatic tunnel is created, what we do is we pass a sling around the pancreas. It can be umbilical tape or any vascular tape. So once the pancreas is hooked up, then we divide the pancreas either with harmonic or monopolar or bipolar or the monopolar, taking care that we have a proper hemostasis and taking care of the pancreatic duct also. Here in this pancreas we can see that pancreatic duct was quite dilated and we have a gush of fluid coming out of pancreatic duct. So we were quite, in the previous case we had a non-dilated pancreatic duct. This pancreatic duct was quite, it was around about 6 to 7 mm. So taking care that we have a proper hemostasis. So once the pancreas is divided, then the next step is this is the superior mesenteric vein. Next step is, of course, the taking of the uncinate process from behind the vessels. And again, the ligashore comes in our, there are many vessels which go from uncinate process to the portal vein, and ligashore helps us in these conditions. We remove the uncinate process from the portal vein. And once the specimen is out, this is so much time is taken even just for dissection phase. So once this whole lymph nodes between the portal vein and IVC at the origin of superior mesenteric artery are taken care of, then we place this specimen inside a bag and park it aside the abdomen. Now starts the reconstruction phase. This is the hepaticojejunostomy, end to side hepaticojejunostomy we are doing with the warped suture, single layer. Continuous sutures. If the bile duct is not dilated, we can use interrupted sutures, and the sutures has to be so that they are not too close, they are not too far away. And in this case, we used continuous sutures in this. Once we have closed the posterior layer, then anterior layer is completed, and these warped sutures are very nice. They don't loosen up so easily. So once the hepaticojejunostomy is completed, next is the pancreatojejunostomy, which we use almost 15 centimeter away from hep-J. So this is again a very crucial step in doing the pancreatojejunostomy is the ductojejunal anastomosis. So this is the posterior layer which we are using 3-0-proline, where we are anchoring the pancreas to the jejunal wall. and it is in a continuous way, continuous sutures. So once this posterior wall is, anchored with the jejunum, then we will be doing a jejunotomy and a ductojejunal anastomosis. Here also we have to be sure that the sutures are not too tight, hemostasis has to be proper, and again this anchoring is very, very important. And then we leave this suture here, and then we will be doing a jejunotomy. And after doing a jejunotomy, we place a feeding tube inside the pancreatic duct, and we do ductojejunostomy. Usually this is done with the PDS 30. We suture the pancreatic duct with the through and through hole of the wall of the jejunum, and usually this requires 3 or 4 sutures. We can take a U suture between the pancreatic duct and the jejunum. This is a classical Blumgard's technique where sutures has to be, if we keep these sutures too loose, you get all confused. So it is better to tie these sutures individually and keep the stent inside the pancreatic duct. So this is the posterior layer of the pancreatojejunostomy being done. After that, we will be, again placing the stent inside the jejunum as well as in the pancreatic duct, which will stay there for at least a couple of weeks, so that this this anastomosis heals up. This is the most tricky situation because pancreatic fistula is the most, critical in these patients. And we have been very lucky that there was no such occurrence in our patients, and they did very well in the postoperative period. So once the posterior layer is closed, we place this feeding tube inside the pancreatic duct as well as into the jejunum, and close the duct with the anterior wall of the duct. So we take the through and through sutures from the pancreatic duct and join it with the jejunal wall, through and through sutures. Again, we 3 to 4 sutures are required in this, but you have to be very, again PDS is used. In the last case, in one case we used Vicryl 30, no problems. It also went very well, but in this case we used PDS, which has a tensile strength, good tensile strength of 4 to 5 weeks. Once the pancreatic duct is closed, then we again the fourth layer is again continuous 20 proline. We anchor the pancreas over the the pancreas over the jejunum, and these are continuous sutures.
Dr. 3, we are falling short of time. Please be quick now.
Just 2 minutes left. Just 2 minutes left, and I think we will be through it, because we will be just doing a gastrojejunostomy, posterior gastrojejunostomy, a feeding jejunostomy, and putting in a drain, and that's all. So to reconcile a 8 hours video into a 6 minutes, we did a posterior gastrojejunostomy, stapled gastrojejunostomy, and a feeding jejunostomy in this patient. This patient went very well, and we removed his feeding jejunostomy after 3 weeks. Drain we removed after some 7 days, and the specimen was removed from the infraumbilical incision of 3 centimeters. Just few slides. This is what the data suggests. This is what the data suggests. We have our Indian Palani Velu sir. He has done 42 cases. This is the report of 2007, and he had a conversion rate of minimum conversion rate. Almost 100% he attempted. He completed the procedures. So as more number of cases we will be doing, so there will be problems. So this is what literature supports, that pancreatoduodenectomy done laparoscopically is here to stay, and it is feasible, it is very safe, it follows the oncological principles, it has all the benefits of minimal access surgery, but only drawback is it requires advanced surgical skills, it requires stamina, it requires a team which supports you whenever you are in a trouble. Thank you so much. Thank you so much, sir.
I think there will be no comments because we are running short of time. We will start this next session. Thank you.
Thank you so much, sir. I like to, have some comments from the legions who are the students of pancreas, Professor O.J. Shah and others who, Dr. Manzoor, sir,
yes,
pancreas, left and right.
Yes.
Yes, 1 minute.
You see, I would not interfere. Actually, time is very important in life. The advanced age you get, you see the road is short ahead of you. The problem with humans is that we start hurrying up towards the end of life. That should not happen. Anyway, the thing is that you have reached a stage in life here in this region where you are able to do laparoscopic surgery of pancreas. It's a great, great pleasure and honor to listen to people like you, stalwarts like Nazir Saab there, Mumtaz Saab there, all his friends there, all the colleagues who have come from west or east, all the legends here. This is the best time here in this region. When I can hear about pancreas happening laparoscopically, it draws my memory back to 27, 28 years back. And once I see Makhdoumi there, he was my registrar. I had just qualified out, and he is asking Dr. Vani, peace be with his soul. We lost him very early in life, a legend, who started actually Whipples here. In 80, 85, 84, 85 I was with him. And then he started the story, and he was very close to me, and we slept together sometimes in my flat in Delhi. I asked him, how did you do this, Whipples? How could you do it? He told me, I did it there. I told him, I thought that you did it in England once you were with Dr. Bahajuddin and other things. No, I did it there in Skims. Then once we traveled back, I said to my mind, if he could do it, why can't I do it? So it happened in 1996, late 96, let's put it somewhere in January 97. I started my journey of Whipples. And Makhdoumi was there, and they said that, oh, you cannot do it. But he was the only person who said that he can handle the tissues with hands. And Divsakarna. So there was a lot of fire happening below, which I didn't realize, but it happened, so I saw it afterwards. But then I had gone up that time. The thing is that it went up. 2000, since 2000, I focused only on pancreas in my lifetime. Two things I focused. This is a message I want to give to the youngsters right now. I focused only on portal hypertension and on pancreas in my lifetime. And both procedures, I was so lucky to handle most of the complications what I recorded all over the world. Right from Henry Bismuth to Marshall Orloff, they became very close to my mind. And I modified both the techniques all over the world. And the legendary Denton Cooley went away, and he just wrote to me once, and he took this manuscript of Splenodenous Chant and he got published it in American Journal. Anyway, that is a different part that excites you. But what I would suggest here, in a nutshell, make a multidisciplinary team. The most important factor in such surgeries is the higher you go, more complications you get. The failure to rescue, understand what I am telling you. Robotics is going to be worldwide, but it's going to be used in battlefields for Americans. Remember what I am saying. They are training their army surgeons, telemedicine, because unless they are aggressive to the world, they will not have a cool night's sleep with their all endures what they do. And it will be at the cost of human life. I may be very political here, understand. So you try to listen and try to bring up a multidisciplinary team. We are a poor country. You must have so many pancreatic surgeons. I know people die. They will still die. But what you mark in lifetime, you mark it. Make a multidisciplinary team. And that is the answer. Thank you very much.
Thank you, sir. Thank you, sir. Thank you so much. Thank you so much, sir. Thank you so much.
Thank you.
Thank you, Dr. Atri.
With this, we conclude the session. I thank all the chairpersons for their valuable time. We felicitating our chairpersons. I request Professor Munir Khan sir to kindly come up on the stage and felicitate our chairpersons. Sir, please. Professor Mumtaz sir. Professor Nazir Ahmad sir. Professor Shamsul Bari, sir. Dr. Zafar Salim. Thank you, sir. Now I request Professor Baldev sir to kindly come on the stage and felicitate our speakers. First, Dr. K.C. Sharma, sir.
मैसेज मिल गया कल क्या
Dr. Abid Hussain. Professor Nazir Wani, sir. Professor Ejaz Hasan, sir. Dr. Manzoor Dar, sir. Dr. Abdul Hamid Samoon. Professor M.R. Atri, sir. Thank you, sir. Now we are going to start our second session, which is going to be urology session. For that, I am going to call the chairpersons. Professor Baldev, sir, please. Professor Saeed Sajjad Nazir, sir. Dr. Umar Salim. Dr. Ashik Hussain. Dr. Abdul Rauf Malik.
उमर से
Good morning, sir.
क्या बोल रहे हैं? मैं यूरोलॉजिस्ट कहाँ हूँ?
Over to the chairpersons.
Good morning. This is our urology session. We have two guest lectures in this session. One by Dr. Rahul Gupta and second by Professor Arif Hamid. So I will request to
Sir, this is a little change.
Slimani and Arif. There is a change in the program. The Dr. Professor Salimani, HOD, urologist, KIMS will be speaking on his topic, the guest lecture, transplants, kidney transplant surgery. हमारे में इसलिए कितनी इसके बाद गुजरा अब हमें ही करना है ये चीज
Good morning to everyone. At the outset, I bring greetings from the Sher Kashmir Institute of Medical Sciences. I thank the organizers of this twin conference for providing me a platform to highlight the work which we do at the Sher Kashmir Institute of Medical Sciences. I am thankful to them that they provided us a link day before yesterday for highlighting a transplant, kidney transplant, which was happening in the Sher Kashmir Institute of Medical Sciences at a very short notice. We had a patient who was around 25 years old from Jammu, and the father was 50 years, donated the kidney, and that transplant was beamed live to this auditorium. I will be talking about the kidney transplantation in Jammu and Kashmir, the challenges and the way forward. I would divide it into two parts. One is that what we do at Sher Kashmir Institute of Medical Sciences, and then what is the way forward. What we are doing, is it sufficient? Do we need any course corrections, or do we need to do modifications in the techniques and other things? Now, chronic kidney disease is a major global health problem, and it's rapidly increasing. Prevalence is increasing both in the developing as well as the developed countries because of the aging population we are facing now, because of the increasing incidence of the diabetes, which is at the top of the ladder insofar as the CKD is concerned, cardiovascular diseases and obesity. What is the magnitude of this problem in India? Is it different than rest of the world? No. It's same if we see in India and if we see in this part of the world. Incidence of the end-stage renal disease is on the rise, 100 to 150 per million population. The only 5 to 8% of these unfortunate patients get the dialysis. Though the dialysis access has been improved with the government, proactive measures of the government, and we get dialysis in, previously it was in Sher Kashmir Institute of Medical Sciences only, then in the GMC Srinagar, and now we have it at the district levels also, and various NGOs have also come up with the dialysis programs. What is the transplant position at this point of time? 1.5 lakh people require transplant every year, and only 4,000 transplants are done each year. And I was asking the SOTO team to detail me about how many cases of the transplants have been done. And there is a website of the NOTO which gives us the details of these transplants. If you see the transplant which we did on Thursday, and how many transplants have been done in the north, Roto, that is around 6 to 8 states of the North India. 11 kidney transplants were done total on this day, and one of them was from our department. So we need 1.5 lakh people need transplants, only 4,000 transplants are done each year. Why so? We would be discussing in subsequent slides. Treatment options for the end-stage renal disease, the best treatment option would be the kidney transplant. Why so? What is the reason? Now, it is a treatment of choice and the cost-effective strategy for management of the kidney failure patients. It improves the quality of the life. These two boys, we did in 2013. They were toddlers that time. They were children, and that time we did the transplant back to back, This time, both these children have graduated and are doing excellent. And this is the photograph on the left side, left lower side is the photograph of these two boys taken after 3 months of the transplant. And one of the boys who has graduated is now there. Post-transplant, we need to highlight these success stories. The reason is that the people should understand they can live normal life. And we have seen, these are the case sheets of the two girls who married after the transplant and had children. They were 4 cases which have delivered in the Trust Hospital of Sher Kashmir Institute of Medical Sciences in last 3 months. 4 female patients married, post-transplant and delivered. 1 patient is currently admitted in Sher Kashmir Institute of Medical Sciences Gynae department, and she will be probably going for the delivery in this week. 2 boys graduated, which I showed since 2013. They are having normal life. 1 girl, which we did in 2014, she did MA Psychology after that. She is now a business manager in one of the pharma companies, and more importantly, she is performing the job of counseling the patients. Is very, very important. And she is doing it privately in her own capacity. We did more than 500 transplants since 1999. I'll be presenting the data of 7 years about the multiple vessels. We had a gentle beginning, and there will be teething problems. There will be problems which we'll have to face, and there will be situations where you will have to crash in. And the crash situations do arise in the transplantation. This is not some ordinary surgery. Here, the 2 lives are involved. One is a donor. It's an unfortunate necessity that we have to take. We have to make a normal human being a patient. And the most important thing is that no harm to the donor. That is the dictum. And when we are doing these transplants, we have to take care of the 2 people, a high voltage surgery, and then it gets nuts to the surgeons when you have complications. And the recent episode of last week, intervening night of this Saturday and Sunday, when a crash situation arose and we had to come to the rescue of that, and one has to be very, very prepared for the situations. And it is the timely interventions which saves the lives of these patients. And one has to be very, very careful and prepared. And you have to be in the state of emergency preparedness every time. My team at Sher Kashmir Institute of Medical Sciences, if it happens, they know where is the key and they know where is the team. And there is a WhatsApp group and everybody gets involved and crashes. We too had crash situations in past where we had to intervene, and unfortunately in 3 of the cases so far we had to do the graft nephrectomies. So this, because these patients are never normal. They have multiple comorbidities, and the team has to be very active and in a state of readiness. We do not sleep when we do transplants. My nephrologist does not sleep. He knows there will be a call at the end of the night and he will respond. We continue to do the work, and so far we do 1 transplant in a week. I have other works to do. With a huge department. We have to train the students in urology, uro-oncology, stone disease, and we have 1 theater. The limiting factor in my institute is not the manpower now. We have produced enough manpower. The limiting factor at this point of time is the availability of the theaters. If we are given 2 theaters, we would do that. My previous administrator, Professor Omar Javed, is here. I have been so proactive and involving, giving him trouble, and he would always come to us and help us. So what we need more theaters, and we need more of the donors The two limiting factors at this point of time is the availability of the donors and the infrastructure. If I do 2 transplants in a week, I will have to struggle for the space. Why do I keep? A patient can come with the complications like rejections. He has to be taken care of. We started it in 1999 and we did not dip during, there was a slight dip during the COVID, but we still continued during the COVID as well. The donors and recipients. If you see the females, unfortunately, will be at the leading role of donating. Mothers, sisters, wives. And the recipients would be mostly males. These are the general statistics everywhere. And then gender distribution and the age. If we see that youngest one was the 14 years and the eldest one was 59 years insofar as the recipient is concerned in these 7 years. This is the distribution of the donors and age and gender wise. Mothers at the top of the donation list, followed by father, 20 cases, then wives, 37, brothers. Then we had some change of statistics in our place because of the proactive role, because of the media played and the success stories. Now we are getting unmarried sisters and daughters coming forward and donating, and we do take them because we know there is no other way but to go ahead with these transplants. The basic disease pattern is IgA nephropathy, then CKD because of the patients coming in the late stages when they do not have the biopsies and their kidneys are already not amenable to any treatment. As I said that we too had our share of bad luck. 3 Groton nephrectomies, 1 had an RCC after the transplant, 1 had APKD, and 1 had grade 4 reflux. Because of that we had taken all the precautions. And we have 1 transplant patient. She is dated for surgery this week. We have transplanted her in 2018 or 19, I don't remember correctly. The daughter was the donor. And that lady, we found that she has the bladder cancer. And we thought that it would be low grade and we will be able to manage her endoscopically. But we are slating her for surgery this week. We will have to do radical cystectomy in that patient with a transplant in situ. Her kidney is functioning and its creatinine is 1 at this point of time. So those are the problems which we have, which you have to face when your volume goes up. What is important is what is the anastomosis time or the warm ischemia time. And when we were demonstrating, we had some problem, link problem. And that time I had to take the patient and I said that we cannot wait the kidneys in ice, we will have to hurry up. So that warm ischemia time and anastomosis times are very important. If you look at the graft functioning and the future of this kidney. Multiple vessels and single vessels. Initially, the multiple vessels would not be taken for the transplant because it would be difficult technically. But now, since the shortage of the donors, and the refinement of the techniques, the multiple vessels are being taken. We had in this set, we had around 26 multiple vessels. Multiple vessels we need to know preoperatively. And one of the transplants which we did, they had shown 1 accessory only. And we went onto the table, though it was not done in my institute, the CT Angio, it was done privately. And once we opened, we found 4 vessels. It was a difficult situation. I'll be sharing the slide of that patient. The graft did well, and our only thing is that the anastomosis time was longer and it was difficult procedure. Each transplant you do, the work, whatever it is, transplant, anything, it is review of the original work and the refinements of the techniques. And what you actually do, what you actually have learned over a period of time, seeing the workshops, the conferences, and learn from the seniors, and then you try to do it and do it yourself, and then do an introspection. Involve the immunologists, nephrologists for the immunosuppression. These all modifications of the techniques and the modern immunosuppressive techniques have really helped us in giving a good result insofar as post-transplant period is concerned. There is when a surgeon does a surgery, he will have complications. Atraumatic surgeons will not have any complications. So the surgeons will have complications if you do the surgeries, and what you have to see, are you within the limits, defined limits of the complication rate? That's very, very important. And once you improvise the techniques, this complication rate goes down. And the most important thing in transplant is the bench surgical part, the bench surgery. Whereas once you harvest the kidney, on the table you do bench surgeries, there are multiple vessels. How do you handle them? How do you anastomose them on table? How you anastomose, or do you anastomose separately or sequentially? Those are the things which you see on the table. Bench surgery, I mean. We too modified our techniques. The most important killer of the transplant surgery is the infections. And how do you counter? This has to start from pre-operative, on table and post-operatively. Because of the immunosuppressants, they will have the infection rate high. And the most important part of the surgery anytime and anywhere is the aseptic techniques, and what we do, how we clean the skin, and we have seen the infection rate by this method of Savlon, chlorhexidine, spirit, and betadine, helping in, and none of our patients gets the wound infection post-operatively. That's very, very important because of what you do. Then bladder, once you open the bladder, it is all defunctionized bladder. It's not formed urine for a long period of time, and once you anastomose ureter into it, you will have complications. And that complication rate can be lowered. We do bladder irrigation with amikacin and betadine on table, and that helps us in countering these complications. One of the MCA student had his thesis on this, and we have found good results. Then how do you anastomose the ureter into the bladder? That's very important. And you have to do an reflex technique. We have modified our technique, and at Sher Kashmir Institute of Medical Sciences, where we do a corner saving vascular anastomosis technique, and where we bury the distal end of the ureter into the detrusor. We have to make it an anti-reflux mechanism, modified Grigor technique or least Grigor technique, where you suture the distal end and anastomose it and bury it, and so that there is a tension-free anastomosis. DJ stenting is done to when there is an anastomosis, and nowadays people are doing without DJ stent. Previously people would keep for stents for 4 to 6 weeks. Now what we do, we remove it very early, and we have found that this to be a very good technique of reducing the infection rates and the stent-related complications. This was the observation about the stent-related complications vis-a-vis early and late removal. Then this is the complication rate. What you should do, you should not hide your complications. You should not be ashamed of showing the complications. What is the problem? Why shouldn't we show a complication rate? What we should do, what we should understand, that we should be within the limits of the complication rates all over the world in other centers. So we too had our complications, ureteric stenosis, ureteric anastomosis, and what is important, what I tell my students, that what is important when you do surgery is not how you do the surgery. What is important is that you should identify the complication early and step in early. Having a bleeding, not admitting, not thinking that I will export. Why? What is the problem? Bleeding will occur. And what is important is that identifying in time and salvaging the patient. So complication rates do occur and we should intervene early in time. Vascular complications, they can be vascular, they can be urological, they can be wound complications, they can be stent-related complications, and there can be lymphocyte because you are doing skeletonizing. Once you are preparing the bed of the surgery, you have to skeletonize the vessels, and there is a chance of lymphocyte formation. And how you clip these lymphatics, that's important. And the lymphocyte formation is common. Then the management part of it, ureteric stenosis, there we have a very good radiology team available with us, and where we do integrate stenting or retrograde stenting to overcome the ureteric stent, stenosis, leaks, and lymphocyte formation. And lymphocyte formation, this is one of the urinary complications where then there was a suggestion of it showed that there is a block in the ureter. We had to do a Boris flap. Open this patient and do a Boris flap. You have to be very careful you are in that anastomotic area. And they do well after that. Then integrate stenting and integrate dilatation of the ureteric stenosis is done, and with good results. Then recently we had a lymphocyte, and the Department of Radiology, they helped us and they did an intranodal leproid lymphangiography and glue embolization in one of the cases. Normally if you have a lymphocyte formation, you can just drain it and sclerose it, but it has to be away from the anastomotic site. Then vascular complications, you need to go in. You have to have a zero tolerance and you need to step in very, very correctly to salvage the life of these patients. We had 27 patients who had surgical complications, which I detailed, and all of them recovered. None of the patients underwent re-exploration and the graft nephrectomy which I showed, it was purposely. Those were graft nephrectomies, they were not out of these group of 7 years which we are showing. And one patient developed graft rejection, and one patient died of respiratory failure during the COVID, and he had a functioning kidney. Then we have to look at what are the risk factors. What are the risk factors would be recipient related. They could be because of the comorbidities this patient has. They are always having comorbid conditions like hypertension, diabetes, atherosclerosis. Then the complication rates, as I showed you, I will show you a slide where this is important. If you see the percentage in skims and the percentage from the literature, this is important, what I was saying. The lymphocyte formation is around 20% of the cases will have lymphocyte formation, and in our case also we had, but it was lower. The wound infection was lower, as I said, detail the reasons thereof. Outcome will be defined by what you have the creatinine level at the discharge and 3 months and a year later. This is the graph of these patients which we had how much time I have? How much time I have left?
About 5 minutes more, sir. Five
minutes more?
Yes, sir,
okay. So I was told that will be 25 minutes.
Yes,
is it?
20 minutes gone, we have 5 minutes.
Okay, so I will have to hurry up now. So what we do is the multiple renal transplant management, as I said, is that what you need to be, if you want to management of these cases, you need to be prepared. You need to be prepared for the management of the multiple vessels, and if you are prepared, the battle is half won. And the armamentarium which you require for these procedures, the most important part is the bench surgery, where you remove the clots from the lumen, extra tissue from the renal arteries. You have to be very careful about the golden triangle, where you have to safeguard the vascularity of your ureter, and you have to perfuse. The perfusion time is very, very important, and you have to be really atraumatic to this kidney, and you have to be very gentle in handling these vessels. Then there will be various situations where there may be 2 vessels, 3 vessels, 4 vessels. How you combine them on table or separately, those are the bench pajama, anastomosis and all those things. I will not detail it here now. Then I said this spare the golden triangle. The golden triangle is that the fat which is at the pelvis, at the lower end of the kidney and the ureter. Because the blood supply, there is no nameable vessel to the ureter, you have to preserve. This is the cardinal thing in the transplant surgery. Perfusion, I said that there are various ways to perfuse, then arterial anastomosis, how you do, and then how you anastomose multiple vessels, and then double vessels. I will skip all these because of the paucity of time, because I need to go to the other part of it, that is how to, what is the way forward. And two cases will be highlighting 4 vessels. In one of the cases, it was only one accessory vessel, and then we had to take the right kidney because there was a stone in the right kidney. So you have to leave a better functioning kidney with the patient. So we had a patient, there it was shown there are 2 vessels, but a stone there, but when we found on the table, there were 4 vessels and a stone. And then we had to remove the stone on bench, and then also do the anastomosis on the bench. We combined 2 vessels in a pajama fashion or trouser anastomosis. One that was anastomosed to the external eye, then one artery was anastomosed directly to the internal eye and to side, and one smaller vessel was anastomosed to the inferior epigastric artery, like the Dr. Sajad's team had last time, the 2 vessels they had done. This is how we managed. Cold ischemia time was 90 minutes. It was higher here, otherwise it would be 20 to 30 minutes only. And on-table diuresis was observed. Post-operatively, he did well. We discharged him at creatinine of 1.3, and at 1 month it was 1.1. And this is the Doppler of the same kidney, day 22 post-surgery. And all the 3 vessels are having good registry index and are functioning. Then case 2 was, there were 2 renal arteries, was a simpler one, and we had to anastomose, there were double vessels on both sides, so we anastomosed them separately, one with internal like and external like, and the creatinine at 1 month is 1.02. And this is the Doppler of the same kidney on day 22. In this part, what I was trying to show, that you will have excellent results if you know what are the complications, if you know how to manage these complications, and if you have modified your techniques, you would be able to get the better results. This is one part of it. Now, what way forward? What is the way forward? Are we doing adequately? Is it adequate what we are doing? And what should be done now? What are the challenges? And what is the way forward? Cadaver transplant or deceased donor program is the way forward. Why cadaver transplant? There's a huge gap between the availability of the organs and the demand. And unfortunate necessity is that we have to do a living donor. We have to take kidney from a living donor. The disparity is there of the donors also. There was a shortage of availability of the donors because of the small families, social limitations, and blood group mismatches. And the act came in, and then because of that, spousal donation, altruistic donations, and the near relative definitions were expanded. And swap.
Professor Salimani, your time is over, please.
You will have to give me some more time, because I wanted one message only, and I'll take 3 to 4 minutes only. So, swap donation is where there is a person whose blood group is not matching and the other person's blood group is matching. So you take a kidney from and swap it. We do transplants under a legal framework, that is the Transplantation of Human Organs and Tissues Act. Okay. And what is the take on the religions? Do the cadaver donations, that's a very important thing. Do the cadaver donations religions permit? Yes, all the religions permit cadaver transplantation. Even the Islamic organizations do recognize brain death, and we need to understand, it is the medical fraternity who need to understand what is brain stem death. And we have to popularize this brain stem death, and once we popularize this brain stem death, then only we will have huge donor pool. People die of fatal road accidents every year, 85,000, and each time there are 8 to 10 brain dead patients in ICUs in the country. And these people can save, these dead bodies can save the lives of 8 to 10 people. And I said that brain stem death needs to be popularized, and we as a medical fraternity need to understand that the brain stem death is legal and permissible. What are the issues and challenges? I said that poor availability of the donors, lack of awareness of concept among the medical fraternity. We need to highlight that. Then how do we take a kidney and transplant it? What are the centers? And for that, awareness programs are very important. We do had our awareness programs in the Sher Kashmir Institute of Medical Sciences. The National Organ Transplant Program under NOTO is the way forward. There is a National Organ Tissue Transplant Organization which is based in Delhi. Then there are ROTOs, which is a regional organ transplantation, and we come under Chandigarh. And we have Chennai, Mumbai, Kolkata, Chandigarh and Guwahati as the ROTOs, and the state organ transplantation. Professor Ilyas Sharma is the nodal officer of the SOTO. He was here with us yesterday. And if we want this huge waiting list of the transplant to be curtailed, decreased, we need to go and look at the future, which is swab transplantation, ABO incompatible transplant, and deceased donor transplantation. If you want to be a hero, donate. Be a donor. And let me, at the end, compliment my team at Sher Kashmir Institute of Medical Sciences, which is Department of Urology, Department of Immunology, dedicated nephrologists, dedicated team of the transplant surgeons who would be available 24/7 for any crash situation, anesthesia team, and cardiology, radiology, and social working networks. I am a small part of this team and a proud member of this team, and we are working at Sher Kashmir Institute of Medical Sciences in a very cohesive manner, and that is a message to Sajad also, that you need to have a cohesive team if you want that your transplant program should come out of the teething problems. Thank you very much for patient hearing.
Thank you, Professor Salimani, sir. It's we will not be taking any questions, but just 2 comments before you end. It must be a proud moment for you. Your first, sir, 1 second, sir, please. It's a proud moment for you, sir, please. Yes, sir.
जब माइक आगे दे दो, अब आगे कर, माइक आगे करो भाई. माइक आगे करो.
I must congratulate Salim Saab. We are proud of you, sir.
Thank you, sir.
We are happy to see that we are on the same footing as in other countries of the world. We worked here. I know Professor Ghulam Rasool, you must have heard about him. Great. He was the second FRCS who came here. He was with me. We came here from the institute. He had an interest for transplantation. We in the Department of Anatomy had a room for transplantation in animals. We did transplantation in dogs. In 3 dogs, 1 dog lived. That Ghulam Rasool, late and dead, he is dead. I must also thank you for your getting donation. In the history of transplantation in Kashmir, we had a patient, somebody might be knowing here, Dr. Bashir Ahmed from Ganderbal. His father was MLA. No donor came. except Mamaji. I remember that Mamaji, his name was Ghulam Ahmad, he was in police department. He donated, he wanted to donate, but the children said, how can you donate? You cannot. But he said, I am not donating the property, I am donating the kidney of my body. The case went to the President of India, but somehow it was solved there. Amma donated the kidney to Bashir Ahmed. It was the first transplant done by one of the greatest Indian surgeon, Inder Kumar Dhawan, from All India Institute. And that Dhawan is also no more. He died 2 years on 6 June. Thank you very much, sir.
Thank you very
Thank
much
you,
for
sir.
the comments, and
we are ending.
it's a pride moment for me having the comments from my teacher. Thank you very much, sir.
We are ending the session. Just 2 comments before you go. It must be a proud moment for you, Professor Salimani, sir. Your first student is a chairperson in your session, and also that this is your alma mater, and we have started a kidney transplant program here. Hopefully next year we'll be presenting a series from the Department of Urology.
Greatest moment of joy
Thank you
for
so
the
much.
trainer is today see the day that trainee surpasses the trainer. My trainee is there. I'm so happy to see him there.
Thank you, thank you, thank you very much. Okay, with this, we are concluding this session.
I thank all the chairpersons for this. With this, we conclude this session. I request Professor Masood Tanvir sir, Principal Dean, Government College Srinagar, to kindly come on the dais to felicitate the chairpersons. Professor Baldev sir, please. Dr. Umar Salim. Dr. Ashik. Dr. Roof. Professor Saeed Sayar Nazir sir. I request you, sir, to kindly felicitate the speaker also, Professor Mohammad Salimani, sir. Thank you, sir. Thank you, sir. We start the next session. For the next session, the chairperson is going Professor Ghulam Jilani, sir. Professor Mohammad Salimani, sir. Professor Mufti Mahmood, sir. Dr. Saeed Javed Qadri. Over to the chair.
It's a matter of a proud privilege and honor for me, along with my colleagues who don't need any introduction, Professor Salimani Saab, Professor Mufti Mahmood Saab, and Professor Javed Qadri, our dynamic organizing secretary, to welcome son of a soil, a Kashmiri who has made us proud, not in this valley initially for some time, but last 25 years or 30 years, he has settled in United Kingdom and made all of us proud. Is none else, the one and only Professor Gulzar Mufti Saab. I am also being given the task of introducing the speaker. Professor Gulzar Mufti did his MBBS from this college. He is the first batch of 59 and turned out to be an MBBS in 63, 64. Did his MS from Jamnagar. Did his MCH from All India Institute of Medical Sciences. And ultimately he shifted to the UK. Did his FRCS from the Royal College of Surgeons of Edinburgh. And for last 30 years he has been a consultant urologist in UK. Though he is in UK, but his heart and soul has been always vibrating for his own valley, and he has been always in touch with us for whatever reasons we have. And we have called him in past also when I was in chair, when Professor Munir Khan was on chair. He never hesitated coming, rushing all the way from London and to be a part of us. His brief clinical profile is that clinically he is a uro-oncological surgeon, academically a teacher, trainer, researcher and author, and managerial work or what's called administrative work as a medical director of the NHS board, medical board of the CARE UK. Presently he has taken a voluntary retirement, though he was telling me that he still has a license to practice, but he just wants now to relax a bit more with little bit of age also turning over. But he still is very, very active. You will be surprised and amazed. He is presently a tribunal member of the General Medical Council. You all know what General Medical Council means in UK. He is a specialty professional advisor to the Care Quality Commission. He is a reviewer of the Royal College of Surgeons of London. He is a non-executive director of the East Sussex Board, and he is, last but not the least, trustee of the British Kashmiri Medical Association. With these humble small few words, with the permission of the organizing committee and my colleagues sitting next to me, I would invite now Professor Gulzar Mufti Saab to come and deliver his talk. And the talk is a glimpse of the future through the prism of the past. Professor Gulzar Mufti.
Excuse me.
It's just afternoon, so good afternoon, everybody. When I was asked to give this talk, I was not sure what to talk about. I thought about talking something clinical, something about prostate, something about radical cystectomy, something about hematuria, but at the end I thought that there are very learned people, big professors and teachers and researchers who would be better suited to talk about big clinical issues. So I decided that I should talk about something else, which would be probably interesting for all of you. I think some of you who don't know me, I think Dr. Jilani Saab, thank you very much for a very nice introduction. I think you have summarized me, what is summarized on that slide. Really a hodgepodge of a mixture of many things that I have been in my life. And therefore today's talk is also going to be a hodgepodge, a mixture of flavors really. We will talk a little bit about the present, a little bit about the past, a little bit about the future, a little bit about SMHS Hospital, a little bit about Medical College Srinagar, a little bit about surgery, a little bit about urology, and also something about Kashmir Urological Society. We begin in the 19th century, and if a patient got acute retention of urine, and if he went to for help in the West, he would go to a barber. And at that time, India rubber had been invented. The barber would give him a rubber catheter. He would take the rubber catheter home. He would lubricate it with nasal mucus. he would self-catheterize and relieve himself. After a couple of months, he would get infected and would perish. We had our barbers too. We too had a barber surgeon in Kashmir. But our barber surgeon never touched acute urinary retention. But he did one urological operation on a regular basis, and that was circumcision. And until recently, I am sure that there are many people, even now, who are circumcised by barbers. And barber did many other things. Now, why did barbers have the courage to be surgeons? I think because Baba was the only person in the society who had the courage and the license to move a razor close to human skin. What happened? Where is the slide? Right, okay, we've got the slide back. And then we come to the beginning of mid-19th century. The Church Mission Society decided that Kashmir was a very ripe area to evangelize. And they came up with a four-pronged strategy. And the two important ones, which you all know, and we all and preach. And teach and preach, many of you might know these two people. Miss Mallinson, who opened a high school, a girls' school in Srinagar, and Tyndall Biscoe Memorial High School. And the idea was teach and preach. And along with that, there was heal and preach. And this was the first doctor who arrived in Kashmir Valley. His name was William Amsley. And on the 8th of May 1865, he wrote in his diary, "Today is a memorable day in the history of Kashmir Medical Mission. From the fact that I opened my dispensary this morning at Amira Kadal Srinagar. To be precise, this dispensary was at Kokar Bazar, Srinagar. He was the first qualified doctor to practice in the valley, and for the anesthetists, if any in the audience, he was the first doctor to anesthetize a patient in the valley. And at that time, he used chloroform anesthetic. And he described, and he was the first to perform a cystolithotomy in the valley. But really, the surgical art was brought to the valley by two brothers, Ernest New and Arthur New, who practiced at Kashmir Mission Hospital. And they established the Kashmir Mission Hospital, Drogjan, which then became which is now the Chest Diseases Hospital. And I referred to this yesterday, they published a paper in Lancet in 1891, the mortality of 10,000 surgical general operations in the Kashmir Mission Hospital. This is one of the very famous papers on audit. They audited 10,000 patients and looked at the complication rate of the patients that they operated. And as you can see, that they in particular talked about bladder stones. And as of the 40 cases of calculus vesicae, the mortality rate was 20%. So 20% of patients with bladder stone died under their care. Now, this brings us to 1946, 1940s. And I believe that the last Maharaja, that's Maharaja Hari Singh, left the state with presents in the form of Kashmir Mission, in the form of Sri Maharaja Hari Singh Hospital, Gulab Singh Hospital, and Yuvraj Karan Singh Hospital. And on November 1946, the SMHS hospital opened its doors to the public. And the first surgeon, first FRCS of the state who started practicing at a SMHS hospital was Dr. Fazlur Rahman. He was a Kashmiri, born in Mirpur. He is the father of modern surgical practice in the valley. He was a strict disciplinarian and was the first to use penicillin on patients. It is said that he used 1 million units of penicillin on a full ward, and a majority of patients at that time that he treated suffered from osteomyelitis. And he was the first to undertake Freyr's prostatectomy in Srinagar. And that brought us to 1947, partition of India, with Kashmir as piggy in the middle. But by this time, surgery had become safe because anesthetic agents and analgesics had been invented. Antisepsis had been invented, Joseph Lister. Penicillin, Fleming had brought in antibiotics, and X-rays had been invented. So began the era of the general surgeon. Bigger the cut, bigger the surgeon. Oops. And this was the era of the big surgeon. There's no awaz. Please, very poor arrangement.
Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look! Have you looked? Yes, sir. See anything? No, sir. Very good, carry on. Gently, man, gently, you're not making bread. Don't forget, to be a successful surgeon, you need the eye of a hawk, the heart of a lion, and the hands of a lady. You found it? Yes, sir. Well, what is it? A lump. Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, don't worry, my good man. You won't understand our medical talk. You, what are we going to do about it? Cut it out, man. Cut it out. Where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. Now, don't worry. This has nothing whatever to do with you. Now, you. When we've cut through the skin, what's the first substance we shall find? Subcutaneous fat, sir. Right. And then we come across the surgeon's worst enemy, which is what? Speak up, man! Blood, you numbskull! You cut a patient, he bleeds until the processes of nature form a clot and stop it. This interval is known scientifically as the bleeding time. You, what's the bleeding time? 10 past 10, sir.
We had our big surgeons too. Dr. Ghulam Rasool, Dr. Girdari Lal. And if you want to read about them, I wrote about them in J.K. Practitioner in 1998. And then came the Medical College, 1959. And I had written a piece on the GMC website. I don't know, I couldn't find it when I looked for it yesterday. And this is what I said. I said, new people, new environment, fear of the unknown. This was a new world for us all, even for the staff who had been hired to teach from outside. And after spending 5 magnificent years together, we metamorphosed from young chicks to young adults and graduated as doctors. As we left our mother hen, our college, like a handful of seeds, the winds of destiny scattered us in different directions all over the globe. And came May 1965, and I just qualified as a house surgeon. And this is Ward 17, SMHS Hospital, just outside theatres. And this was the dressing room at that time. And as a just qualified doctor, I removed a rather large and juicy sebaceous cyst from a young man's scalp under local anesthetic in the dressing room of Ward 17 at SMHS Hospital with the help of my dresser. And little did I know that exactly 100 years before that, on 18th of May 1865, William Elsley wrote in his diary, he said, I excised a cystic tumor from a young man. This is the first time a native Kashmiri has been anesthetized in the valley with chloroform. And 8 days later, Mr. Elsley's patient returned to him and he wrote, he said, the young man from whom I extirpated the cystic tumor called today to show himself, and he presented to me with a 2 rupee note. And my patient too came back, returned with a gift, albeit a live one, a big cock, which was taken for the dresser, who accepted it gladly. The irony was that my patient was under the impression that the dresser was a man who had operated on him and I was just his assistant. If you think of SMHS Hospital, this is how I described SMHS Hospital in my book. I said this is the institution where the seeds of my own surgical career were sown, where I put in the first stitch through the human skin, performed the first ear lobule repair, removed the first sebaceous cyst from a young man's scalp, and reduced the first scoliosis fracture. There are hundreds of others before and many after me in all specialties of medicine who have served and are still serving mankind all over the world and who were taught to stand upright and walk with courage and conviction by the good old SMHS. Great personalities have traveled miles and miles through its long corridors. And during this era of the big surgeon, we had so many surgeons who served who taught and who treated, beginning with Ramchand Khanna, who was our first professor of surgery, Dr. Parmanik, and then Kashmiri, starting with Dr. Ghulam Rasool, Brij Mohan Ban, and Mahmouda Khan, who is sitting in the audience today. And after that, Rashid Saab, Zargar Saab, whom I can see there. And after Zargar Saab came the local graduate who became the head of the department, that is Muhammad Shafi Misga, whose first love actually was orthopedics, but then he joined general surgery. And this was the era of the open surgeon. Give them anything surgical and they could tackle it. And these people taught hundreds and hundreds of our colleagues, my juniors, and my colleagues. And then came early 70s, and I had a surgical problem myself. I had a 2-centimeter stone in my kidney. So I went to the best, what I thought was the best cutter in town, and I asked for help. And I said to him, I said, "Sir, how long will be my incision?" And he said, "I wish there was a way to make a small hole to plug the stone, but I am afraid there isn't." And 20 years later, I found myself assisting John Wickham in the procedure of percutaneous nephrolethotomy at the Institute of Urology for a similar sized stone. We removed this stone through a 1-centimeter scar, whereas my scar was 15 centimeters long. Writing in the BMJ in 1987, Wickham said, future surgery, he coined the word minimally invasive surgery. And he said that the next generation of surgeons would have to be trained as microendoscopists and bioengineers rather than butchers and carpenters. But what you see today didn't happen overnight. It needed 3 things. One was you needed a surgeon, a thinker, to think how we can look into cavities through small apertures. And that was John Wickham, urological surgeon at St. Bart's Hospital, London. You needed a scientist who could come up with instruments of some description by which we could see it, and that was Harold Hopkins at the University of Reading in England. And you needed somebody to put in the money, an entrepreneur, and that was Karl Storz from Germany. Harold Hopkins invented the rod lens system and the fiber optics, and the 3 combined together, and we had the cystoscope, and we moved from candlelight to sunlight. So, as they say, min az-zulmati ila nur, from darkness comes light. And then we had some brave people who braved and came up with original surgical procedures. Eric Muhe was the first laparoscopic surgeon who did the first laparoscopic cholecystectomy. Interestingly, his license was taken away after he did it because he did not get permission for it. And then his license was reinstated after 10 years. Ralph Kleiman did the first laparoscopic nephrectomy. So open surgery was replaced by keyhole surgery. And then 1980s, we had a huge technological explosion. Digital technology, internet, social media, computer technology, and Mr. Wickham's prediction started coming right. And we moved to Kashmir, where subspecialization was already coming in. Professor Jilani came in with diploma in urology from London, and he began to use the resectoscope on Kashmiris and came up with the TR prostate. Could we have applause for him, please? We had the cardiovascular specialty, Ashik Hussain, who was the other specialist surgeon. But really, credit should go to one person who persevered with laparoscopy in the state and in Kashmir Valley, and that's Munir Khan, who is sitting there. And when I wrote about him, I said, despite the prevailing circumstances, Dr. Munir Khan, whose passion with keyhole surgery led to the development of laparoscopic surgery in Kashmir. He conducted several courses and conferences on laparoscopy, having attended a few symposia organized by him I know how passionate he is about this aspect of surgery. And if you talk of big laparoscopic procedures today, I think great credit should go to him. And the laparoscopic era began with him, and laparoscopic era continued until today, when we have Mahmood as the head of the department, who will be departing after a few weeks. And in 2005, the Defense Department Trauma Pod developed a project to develop robotic diagnosis, and this was due to the Gulf War, really. And this brought in robot-assisted surgery, where the surgeon performs surgery by manipulating the hands of a robot from a nearby terminal using precise controls. And in the last 5 years that he has been the head of the department, or 6 years, I think he conducted a number of courses, and we moved now from laparoscopic to robotic surgery. I mean, last year he did a course, and this year he did another course, so 3 cheers for him as well. So, ladies and gentlemen, this all happened in my lifetime. I saw a Hakim in action. I saw a barber in action. I saw a great open surgeons in action, and I was one of them really to be trained, and then had to learn laparoscopy. I saw keyhole surgery coming into play. I saw robotic assisted surgery coming into play. What will happen next? I don't know. And this also happened in my lifetime. We lost some great surgeons. Kashmir lost 2 great surgeons, Dr. Farooq Ashai and Dr. Abdullah Guru. But what will not happen in my lifetime? What is the future? Because this is perhaps the last time I am speaking on this stage. What will not happen? What will be the future impact of technology on surgery? What will be the future of that on our patients? And what will be the future delivery? How will the surgical art be delivered in the future? And that brings me to artificial intelligence, which is to boost the capability of a robotic system in perceiving complex in vitro environments, in order to make decisions and in order to make desired tasks with increasing precision, making it safe and making it efficient. I believe that robotics will reduce the variation in surgical performance. I believe that 3D imaging, virtual reality and augmented reality will enable surgeons to support complex procedures remotely. I believe that big data and genomics will predict the likelihood of disease and improve the understanding of biology, in particular of cancers. And I believe that artificial intelligence will assist with perioperative planning and post-operative care, and provide pre-operative and intraoperative support and assist in post-operative care, and also improve inpatient communication. I think the delivery of surgery, in my view, in 10-15 years will be different. I think an operating theatre will look totally different. It will have integration of digital technology, and theatre space will become more flexible and dynamic. I think the surgeon's role will become increasingly blurred with other clinicians. They will need to understand genomics, genetic analysis, radiotherapy, and bioengineering. They will have to be leaders, they will have to be managers, they will have to be entrepreneurs. The multidisciplinary surgical team will become increasingly important. And those who train must give them knowledge about computing, engineering, molecular biology, data literacy, leadership, team building, and communication. The surgeon of the future will be a clinician, a scientist, an entrepreneur, an educator, an innovator, a manager, and with the ability to move across different roles throughout a career. Something which I probably will not see. But for patients, surgery will prevent, it won't just treat illness. Faster recovery times and lower risk of harm. Non-invasive treatment will make surgery obsolete for a number of conditions. Reduction of inequalities and variation in treatment outcomes will be less between different hospitals, and most of the surgery will be day case or one-night stays. Pre-operative and follow-up assessment will mostly occur through telemedicine and digital platforms. A surgeon could be a humanoid instead of being a human. I think this is what I feel in the Brave New World. I read a book called The Brave New World by Aldous Huxley when I was in my 20s. And one of my uncles saw me reading that book, and in that book Aldous Huxley was talking about test tube babies. And when my uncle saw me reading that, he said, "This is nonsense, you shouldn't be reading it. You know, it's not right." Little did I know that IVF will become a reality in a very short time, and therefore I feel that in the very near future, a surgeon will probably be a human chief who will be dealing with human patients, but he will have robots working under him who will be his surgical assistants. And this is what I wrote in my book, Kashmir in Sickness and in Health. I said that as the concept of robot undertaking a surgical procedure independently on a human being becomes a reality, in the Brave New World, the surgeon may become an antiquated entity. At best, the human surgeon may find a role like the conductor of an orchestra, working on a large keyboard in a large office, directing a pack of androids who will be the surgical workers of the future. But that's about surgery, and let's talk about the present. And the present is that we have come a long way. Compare what SMHS Hospital was in 1947 and compare what it is today. When I did my MCH, at that time I was the only one, and today we have so many urologists. We have urologists at SKIMS, Salimani et al., urology at SMHS, Mahmood et al., Super Specialty Hospital, Sajjad Nazir et al., Kashmiri urologists working in the UK, USA and other countries, urology in the private sector, Jilani Saab, Munir Khan et al., urologists in the towns of Kashmir Valley and urologists in the Medical College of the Valley. So Kashmir Urological Society is a big society. There are a number together. But they are together only if they stay together. And I appeal to them, all of them, one by one, personally. Coming together is the beginning. Keeping together is progress. Working together is success. Thank you. God bless you.
Thank you very much, Professor Gulzar. You have taken the chairpersons and the audiences spellbound by your amazing talk. You have taken us to past, you have taken us to present, and you have also given us a glimpse of the future. Now I'll request my fellow colleagues in the dais, fellow colleagues in chairpersons to take over, and if they have any comment or something.
Firstly, from the core of my heart, I congratulate Dr. Mufti, who was one year senior to me in this very college. And he has done so much work. And this is what I have been pleading since few days to all these doctors, that we should have a museum here. We should have a museum where the innovators of this college, those who have created something, name it as Innovators Museum. Younger generation will go and come and see. Look at Dr. Fazar Rahman, who did Dr. So right from the beginning, the history they will see and they will get stimulated. That is my request again and again to all the authorities, that there should be a museum. There should be a museum here. Second thing, first time I am hearing the referring Bakshi Ghulam Muhammad. What a brilliant man. उसको कहते हैं टांगे वाला है. और टांगा वाला चलाता है, but there is a brilliance with those tanga walas also. And look, best people he got as a teachers here, all the way from the country, without considering Article 370 at that time. And see, today this college is all due to that man, the single person who did so much work. That is what a great credit. And again one request to you all of you sitting here. पूरी लाइफ में just select एक आदमी ढूंढिए, क्रिएटिव आदमी, रोड साइड वाला है, पढ़ा लिखा है, अनपढ़ है, मांगने वाला, मस्जिद के बाहर बैक कर रहा है, उसके पास भी बहुत ब्रिलियंस है. Please look at him, collect him and tap him. You have to give him nothing.
Thank you very much.
He'll feel encouraged.
Thank you very much, K.C. Sharma. I
Thank you,
request
sir.
now Professor Mahmood to have a winding up comment.
Thank you, Professor Gulzar. Yes. Yes, sir. Please go ahead.
Give him the mic. Give the mic to you.
No words to thank the great Mufti.
Thank you.
Greater. Will be the greater. What will happen to us in coming years, I can also predict. There have been lot of times before us when there was no name of medicine and surgery. Diseases used to occur and they used to get healed also. आदम को खुदा मत कहो, आदम खुदा नहीं, लेकिन खुदा के नूर से आदम जुदा नहीं. You are telling what will happen after 10 years. What will happen? A time may come. There has been a song also, Dam Maro Dam. Who knows? By blowing something into somebody's mouth, we may cure. This was a Prophetarian character. And among us, prophets will not come, but their rays will come. We may get healed. This may happen. Roberts may disappear.
Thanks. Thank you very much.
Thank you, Professor Zagar. Thank you, Professor Gulzar. I think your lecture, as always, has been mesmerizing for the audience. It has been really unconventional always, and always thought-provoking. Today's lecture in particular had a strong message for all the youngsters who are practicing urology in particular. And it's my fervent appeal to all the urological community here, especially the members of Kashmir Urological Society, that they have some commitments to this towards the people of Kashmir. And please work towards that commitment and shun away your personal egos and differences. Thank you very much. I am really grateful that you traveled all the way from UK for this event, and that shows your commitment that your body is there but your soul is here. Thank you.
Can I request, in view of the amazing lecture that Professor Gulzar gave and came all the way from UK, rushing, can I request all of us to give him a standing ovation for a minute? Thank you very much, all of you. Thank you very much, all of you.
I am humbled. I am humbled. Thank you.
Well, that brings us to the close of this session.
Sir, with the permission of the chair, I have an announcement.
Actually, Lal sir has to catch a flight, so he had a keynote address scheduled. So I would request the chairpersons to continue and introduce Professor Lal.
Sir.
I would request Professor Iqbal to join the chairs. I request Professor OJ Shah. I request Professor OJ Shah to join the chairs, please. I request Professor Nisar Ahmadwani to join the chairs, please, sir. Mufti sir, please continue there.
It's my privilege and honor to introduce another doyen of surgery, Professor Pavinder Lal, who hardly requires any introduction. He is a well-known figure. But for the benefit of the audience here, let me tell you that he is Director, Professor and Head of Surgery, MAMC and Allen Hospital, Delhi. He is a well-acknowledged and reputed laparoscopic surgeon. He is a recipient of Dr. B.C. Roy Award. He has been former executive and director and CEO of National Board of Education, National Board NBEMS. Professor Pavinder Lal, please go ahead.
Thank you very much, Professor Mufti Masood Mahmood, for that kind introduction. And it's really my honor and privilege to be here at the invitation of the Department of Surgery. And I'm completely bewildered at the amount and array of work that the department has done over the last so many decades. And I'm actually completely moved to be here today, this morning, amongst the stalwarts of the surgical fraternity that this soil has produced over the past 60 years. So it's completely my honor today to be here, and I'm very thankful to the department for this kind invitation and for this opportunity to be a part of this grand UROSURG meeting, which has showcased the advances in minimal access surgery in both surgery and urology. And it's going to make many surgeons inspired to do bigger surgeries through lesser incisions, making the surgical recovery much better. And the topic that I would like to share with you this morning is an operation which has come in the last few years, which we describe as the E-TAP repair, which was described by a surgeon several years back in open era. And Professor Khan, who is here, would be well versed with the procedure that was done at that time, the Reeves-Topa repair, which was done open, that is now just being converted to in the laparoscopic era. So I bring greetings from my institution, Maulana Azad Medical College, which is almost as old as GMC Srinagar. I just realized our first batch was 1958 and your first batch was 59. So they were all growing together. And I work in the hospital which is associated with it, which was earlier called as the Irvin Hospital. Now it is known as the Lok Nayak Hospital. Much to the disappointment to all of you, I have no disclosures. Unfortunately, we are not allowed any private practice. I am a full-time academic. And that is the reason I'm not able to fill in my faculty positions in my institution, because there are much more incentives that are given to the current day surgeons, and we find it difficult to engage faculty and retain them. So at the end of this, I would be able to provide to you a brief history of the glimpse of this repair for ventral hernia, discuss some of the current guidelines, the anatomy of the Reeves Stopa space, and then take you through the steps of the ETEP operation. Now, as I said, the history of the retromuscular repair goes back to René Stopa, who first put forth the concept of the preperitoneal placement of a large prosthesis, and this was way back in 1965. And this was modified by Wandts, and then Jean Reeves introduced the concept of the current retrorectus mesh repair in 1966, and this is the one where we now say is the right place for the mesh to be. So as we were talking yesterday in the sidelines of the meeting of the conference with some of the surgeons who are practicing in areas where there is a challenge to get prosthetic meshes, this space provides us the avenue to place the mesh, a normal polypropylene mesh costing less than 1,000 rupees, and no fixation needed, and just skills needed to make the space and perform the work there. So these were the pioneers, Jean Reeves, who described his landmark paper, and then René Stopa, and combined today this is known as the Reeves Stopa repair. And this is the giant prosthetic visceral replacement or reinforcement of the visceral sac. The operation which is the GPRVS, which we used to do as an open operation. Thankfully, I never did the entire thing together in my life, and but our seniors here, madam who is sitting here, and many of the stalwarts of GMC Srinagar and of this valley would have definitely done this operation in their times. And Wandts made it for the unilateral side. So when we do the unilateral Stopa, it is credited to Wandts. Now, in the current age, it was Jorge Dias who described this ETEP. Now, what is this E word? It is either the enhanced view or the extended view, totally extraperitoneal repair for ventral hernia. And he described this technique for inguinal hernia, which I was able to showcase yesterday in the live operative workshop. And Igor Belyansky, another contemporary surgeon, extended this in the abdominal wall arena and described the paper, which is now becoming the basis for this ETEP repair. So that's Jorge Dias and that is Igor Belyansky. They're all contemporary surgeons working in the US and in Colombia. Now, what are the guidelines for laparoscopic repair of a primary ventral hernia? Hernias which are not because of an incision, but because of the congenital defect or weakness of the abdominal wall. The guidelines say that the defect should be closed whenever possible and the mesh should be placed in the preperitoneal or the retromuscular position with at least 5 centimeter overlap on either side. And though the strength of the recommendation remains weak, we need to do more studies, and therefore there is scope to do more research in the form of thesis topics, which the department is also struggling. I'm told every surgical department is struggling to give topics because of the increasing number of postgraduates. Now, this is the anatomy of the ETEP repair. We go into the retromuscular repair on the retromuscular plane, and then we combine the two sides together. That is the difficult task. You have to go behind one rectus muscle, then you have to do the crossover on the other side, marry the two together. And you cannot marry without dividing the posterior rectus sheath, because the posterior rectus sheath is the barrier in between, because it is going into the linea alba. So you have to divide the posterior rectus sheath of the left side if you are going from the left side, then divide the posterior rectus sheath of the right side, then combine this space into a single space, and then go on to make a large retrorectus space.
And from the top down, when you go in the inferior part below the umbilicus, you see the same TEP plane which you see in the inguinal hernia. So the whole cavity becomes one large cavity which can be an opportunity to place a large normal polypropylene mesh and avoid the expensive dual meshes or even tackers. Now the anatomy, this is very important, and if I have a pointer here, if you have a pointer you can show it to me, but I can, I can bring the mouse here. So this is the layer for the benefit of the younger surgeons and postgraduates. It is important to see that the transversus abdominis insertion comes way medial. In fact, the insertion comes behind the rectus muscle. So when you are in the retrorectus space, you are actually having the posterior rectus, the insertion of the transverse abdominis there. And if you wish to enhance the space, you can do what is known as the transverse abdominis release or the TAR division. Now, this is an important slide for the exam going students to understand that the definition of the meshes has now been standardized. When you put it over the anterior rectus sheath, it is known as the overlay repair. When you bridge the defect, you cannot bring the two together. You put a mesh in the middle, it becomes a interposition or an inlay. The right position is the blue, which is behind the rectus muscle, which is the sublay. When you put it in front of the peritoneum, it is the underlay, preperitoneal, and when you put it intra-abdominal, it is the IPOM, which was talked about this morning. And if you see this anatomy, this is now imperative that all cases of ventral hernia undergo a CT scan of the abdominal wall to study the abdominal wall musculature. And here, very interestingly, you will be able to see please focus your attention not on the three muscles, but just on the inside muscle, the transverse abdominis, and see the insertion of this muscle is way medial to the lateral border of the rectus abdominis muscle. So when you are in the retrorectus plane, if you need to have more space, you can divide the transverse abdominis and you can expand the space so that you can bring the posterior peritoneum and close the large defect, and also bring the anterior abdomen and close the large defect in the abdominal wall. So that is the importance of doing the CT scan. So the salient features of an extended view TEP operation is that it is fast and easy to create an extraperitoneal space, providing the surgeon with a large surgical field to place a non-coated mesh in the extraperitoneal space, thereby decreasing the risk of intestinal and vascular injury or a herniation at the trocar site with improved tolerance to pneumoperitoneum if it was to happen. So what are the steps? I will quickly take you through this. Creation of a retromuscular space on one side, crossover to the other side, opening the peritoneum around the hernia defect, reducing the contents which are the hernial contents through the defect, closure of two defects. One is the peritoneal defect behind and one is the sheath defect on the roof, and then placing the uncoated mesh. There are hardly many contraindications except if there is a previous surgery, then the beginners are requested not to do that because of the fibrosis. Mesh infection and presence of an enterocutaneous fistula remains an absolute contraindication. So I'm going to show you here the port positions. This is the 12 mm port in the costal region. We tend to go almost above the costal margin after the pneumoperitoneum, so that we go to a higher point to do a crossover, which is at the highest point just below the Xiphi sternum, because here the falciform is thick and you have lesser chances of opening up the peritoneum and creating a pneumoperitoneum early on. And then these two are the 5 mm ports. This is the primary ventral hernia for which this is being done. So quickly through the pictures first to make you oriented. This is the introduction of the first trocar behind the left rectus muscle, putting the needle to put the first port. Port comes in, the second port, and then beginning to do the dissection, the division of the posterior rectus sheath on the right side to see the falciform ligament coming up, extending this division, going to the other side. This is the linea alba on the top, and this structure now, may I ask, what is this structure which you need to divide to go to the other side? The posterior rectus sheath of the right side. Now this is identified by the slight pinkish hue that is there because of the rectus muscle behind it. So we divide that, we see the muscle, which is good news, pull the posterior sheath below, and then place a trocar on the right side behind the right rectus muscle, and you have your left and right hands together, and then you go down dividing the posterior rectus sheath on the right side and the left side serially down. This is the linea alba which stays on the top. That is the hernia which is now coming up. Reduce the hernia and go down, marrying the cavity all together into a single large space, and then closing the defect on the roof, closing the defect on the floor, and then placing a mesh either on the roof or on the floor and completing this hernia. So just a quick video. The SIM pictures were taken from the same video. So we do an optical view entry as we did yesterday. Left rectus muscle, tilt the trocar downwards so that you don't puncture the posterior sheath. 0-degree telescope, 10 mm to do the blunt dissection. You are behind the left rectus muscle, making the space now on the left side of the rectus. On the lateral side is the neurovascular bundle. So we need to respect that. We need to keep that intact so that you do not devascularize or denervate the rectus muscle. And this is the TEP plane below. So the whole blunt dissection has been done right from the top. Now the needle comes in to identify the port. So that is the first 5 mm port, which will take the camera when you do the crossover. This is the second port at the level of the umbilicus. The second port also comes in. Now the 5 mm camera comes in, and this is the 12 mm through which we had gone in initially. And now we do the crossover. It will be easier for you to understand because I have shown you the pictures already. We are doing the division of the posterior rectus sheath of the left side. And we try to do this at the highest point because there the falciform is thick. If you do it lower down, the falciform is thin and you will create a hole in the creating a pneumoperitoneum, and you will have a problem getting the space. So we do the dissection, the linea alba is on the top, and now this dissection is going over to the left side. That is known as the crossover, and space is being enlarged so that you can have a good space to go to the opposite side. And then you identify the right posterior rectus sheath, which I said is a little bit having a pinkish hue because of the muscle lying behind it. So you do that division. As soon as you have done a little bit of a division, bring in your left hand through the umbilical level port and grasp the posterior rectus sheath so that you can pull it down and increase the space as much as possible, because there the 5 mm port is going to come. So you are going to put the 5 mm port, which is becoming the right hand of the surgeon, there behind the right rectus muscle. The camera is again going to become 10 mm, the initial one. So we have got enough space and the port is going to come in. Now this is the 5 mm dissection going on the right rectus muscle just to increase that space. Now we are back to the 10 mm camera. We have got the left hand and the right hand in position. You are now working craniocaudal. So you are seeing the linea alba on the roof. Right PRS is being divided, left PRS is being divided, and you will progressively go down, marrying the two recto-rectus spaces into a single cavity that I had shown in the schematic diagram earlier. So this way we keep going down. One has to make sure that you do not divide the linea alba. So linea alba you can see is a white structure, that is the strength. The anterior rectus sheath, the linea alba and the anterior rectus sheath of the left side, they are the anterior wall. We don't need to divide that or weaken it. So we are dividing the PRS and we go progressively down. That is the hernia that is being reduced. When you reduce the hernia, peritoneum is going to open up. There will be a pneumoperitoneum, but it is of no consequence because you've already done so much dissection that the two spaces are equal pressure. It will not hamper your way. So you reduce the hernia. This may be omentum. This can be bowel. You can easily, manage that. So there is going to be a hole in the floor side, which is the peritoneum. And then after this is reduced, we go down. The two rectus muscles, the posterior rectus sheath is deficient below the arcuate line. So you go up to the arcuate line, that is still the lower part of the hernia, which is getting reduced. And that is the last bit. Now we are into the TEP plane of the inguinal hernia. Everything has been brought down. You can see the two rectus muscles going down south, and it has been converted into a single large cavity. This is the TEP inguinal hernia plane. We don't need to go there too much except to make a little bit of a space so that the mesh comes in nicely. So you can see now how glad Jean Reeves and René Stopa would be that what they used to do by cutting open the whole anterior abdominal wall, the current day surgeons are able to do without doing any cutting open, and just by keyhole surgery they have gone. So this is the lower part. You can see the arcuate line and the posterior sheath deficient below, and this is a large single large cavity. So now comes in the stage of the repair of the defects. So I'll just take, now this is the barbed suture. You take the defect, we'll just leave the defect on for the peritoneum, close the defect on the roof so that anterior repair has been done adequately. And once you have done that, then you introduce the normal full 15 by 15 mesh. I prefer to put it on the roof. People tend to put it on the floor. Does not make any difference. I just feel that the mesh should be where it has to be. If you put it on the floor, it will be going up. It is better to put it on the roof where it has to stay. So you can see a normal retrorectus space from one neurovascular bundle to the other neurovascular bundle takes 15 mm only. Does not take 20 mm, takes only 15 mm. But vertically, you may go up to 30 centimeter. You can go put one large, now see now we are doing the centering. This is not a good centering. So I'm checking the centering, pulling the mesh really up so that the needle comes right from the center. In fact, it should come and cover the ports which we have put in. All the ports get covered by the mesh. So you can see the defects are going to get covered, you see, and then now when this mesh comes in here, I cannot put my hand instrument inside because the mesh has covered it very well. And so the mesh is now rightly positioned, and then you desufflate under vision, making sure that there is no wrinkling, no fixation devices are required, and patient has got zero pain. At the end of the day, when the patient comes out of surgery, they say there is no pain. The VAS score is 0. And they go home the next day and they are on no pain medications at all. So to conclude, Chairperson Sir, ETEP for ventral hernia appears to be an emerging procedure for primary ventral hernia for sure. It has a learning curve which once mastered, enables the placement of a large mesh in the retromuscular plane, which is currently the favored plane to place the mesh, and it has the potential to add the transverse abdominis release to enable restoration of the human abdominal wall anatomy. And I'm always reminded that a surgeon has to keep learning all his life and to keep pace with newer techniques and advances. And for that, I frequently quote William Faulkner, who used to say, "You cannot swim for new horizons until you have the courage to lose sight of the shore." Thank you very much for this patient hearing.
Thank you, Professor Pavninder Lal. First, I would like to thank you for coming here and delivering such a wonderful talk and the surgeries yesterday. We will not detain you, sir. I'll request Professor Masood Tanveer, our Dean and Principal, to honor you because the flight is probably on the runway for you. Next time, we would like you to stay here for some more time. Now, can I request Professor Gulzar Mufti sir to please be felicitated there. Professor Masood Tanveer to stay. So we have tried to talk to the airport authorities for you. Okay, sorry. And Professor Gulzar Mufti, I was not able to make the comment that time. Sir, we welcome our seniors. This department will see no change in the management at any point of time. Urology is part of general surgery and it will remain a part of general surgery here. And you will be welcomed the same way in future till we are alive. I hope you will get the point. Plus, I must thank Professor Umar Javed sir. He has revitalized. He has revitalized the menu. Because I want to understand that we welcome our seniors.
With this, I conclude this session.
Just a minute. And I would like to inform you, sir, we welcome our seniors. Professor Umar Javed is a witness to that. In the last 3 months, he has performed 9 Whipples in our hospital. A big round of applause for him. So we'll be expecting Professor Gulzar Mufti again sometime in near future.
I would request the chairpersons to take their seats in the auditorium. Thank you. I conclude this session. For the next session, may I call the chairpersons? Can I have Professor Munir Khan? Professor Mohammad Salimani. Dr. Sajid. Is Dr. Sajid around? Dr. Sajid, please join the chair. Dr. Zuhur. Dr. Manzoor. Dr. Manzoor Chalku. Dr. Javed, please join the chair.
Thank you, organizers. Now we have a talk. Okay, fine. We have 2 talks during this session. One will be from Dr. Arif, who is Professor of Surgery at Sher Kashmir Institute of Medical Sciences. He is my anchor man at the SKIMS, and we have grown together, and he is a wonderful surgeon and a wonderful urologist. And I again say that he is the anchor man at Sher Kashmir Institute of Medical Sciences. Whatever we do there It's all credit goes to him. I invite Dr. Arif Hamid, Professor of Urology, for his talk. He will be speaking about the screening and early detection of prostate cancer. Does it make a difference? Dr. Arif, please.
Respected chairpersons, respected teachers, faculty, dear students and friends. Well, my talk is different. Being a surgeon and speaking on any topic, we are mostly interested in seeing the photographs, the diagrams, the videos, because that makes it a little interesting. But at the same time, as surgeons or clinicians, we have other responsibilities as well. And I chose this topic with a purpose. That apart from what we are doing, the wonderful presentations made by Professor Gulzar Mufti about the evolution of surgical history in this part of the world, how it has evolved over time, it is so fascinating and so interesting. And similarly, Professor Salimani sir telling the history of renal transplantation at SKIMS, how we evolved. I mean, those presentations are really interesting. But this topic, I suppose, is equally important. If we see the lot of literature and data in West, there is tremendous work going on vis-a-vis prostatic cancer. And every year, you have so many recommendations, you have so many guidelines. When there is a topic that it keeps on changing the recommendations and the guidelines, that means it is itself not settled as such. If we look from a simple point of view, that screening and early detection of any cancer, logic would say yes. Screening, early detection, yes, automatically has the benefit. Early detection, screening, you could treat early and it would appear so simple. But prostate is one area where it's not that simple. Because you could question this screening or early detection itself. Is it really needed? Are there any benefits? Does it really make a difference? So to address this little complex question, I have tried to make a presentation and try to make it as simple as possible and do some justice with it. So, as most of the urologists are aware about the epidemiology and natural history of the disease, but since we have students here, so a little background about the epidemiology. We have around, this is the data from the West, we have 1.4 million cases annually detected in US, second most commonly diagnosed cancer in males. Among the males, it's the leading cancer, accounting for around nearly 30% of the cancer diagnosis. So this is just a little word about the epidemiology. See, the natural history is, without screening, many cases of prostate cancer do not ever become clinically evident. So they are not evident. And it often grows slowly, that most males die of other causes before disease becomes clinically evident. At autopsy, we see around 30% of the males in their 50s and 70s having this, and they never manifested during their lifetime. So this is again little, I would say, interesting as well as little thought-provoking. The 5-year survival rate in prostatic cancer, if it is local or it is locally confined, is 100%. While as if it is a metastatic, it's 30%. So again, the question here is that this is one area, one tumor in the body where we usually talk in terms of a 10-year survival, not the 5-year survival. So that is why screening, early detection does have a significant impact. If we again see the Western data, from 92 to 2017, there has been, the mortality rates have decreased from 39 to 19 per million persons in US. And simulation models have shown that possibly most of it is because of the screening of and early detection of prostatic cancer using the gold standard marker of PSA. So these are certain graphs which show the decreasing trend. These are good from the epidemiology point of view, but they do convey their message that over a period of time, because of the screening and early detection, catching the disease early, it has significantly decreased the mortality as well as morbidity. Now, once we talk about the screening or early detection in prostatic cancer, what is the marker? What is the way out? As most of us or all of us know, it is the PSA or the prostate specific antigen. So that is the hallmark of screening. It was discovered in 1970, it's a glycoprotein, most widely used oncological biomarker, approved by US FDA in 86, and later for prostate cancer in 94. It aids in the diagnosis as well as follow-up of these patients. So this is a specific marker for screening and early detection and even follow-up. The onset of widespread PSA screening in late 80s is widely acknowledged to be the primary cause of sharp increase in prostate cancer incidence. So you can see here, because of this marker, we could see a sharp incidence. The detection rate has gone up. And later on, it again fell because there was again a controversy surrounding whether we should do screening or not. So we can still attribute that it was because of the screening and early detection, we had higher detection rate of prostatic cancer. And once the protocols, the guidelines were changed, the scenario again changed. But here we got to know that PSA, it's not disease specific. There are other conditions we have to bear in mind. It may be raised because of prostatitis, because of infections, because of a benign prostatic pathology, trauma. We may have done some procedures like biopsy or cystoscopy. And with age also it rises. So we should have an age-specific, age-calibrated PSA levels as well. So each and every aspect is equally important. And larger prostates make more PSA. So the size is also important. So you can see there are so many things one has to keep in account. Similarly, PSA, it's not perfect also. There's a sensitivity of wide 35 to 70% and specificity of 60 to 90%. And sensitivity of biopsy and screened is at the best is around 60 to 80%. The traditional PSA cutoff of 4 is no longer an absolute indication for biopsy. So the things keep on changing, making it more and more difficult to have a standard or a uniform guideline. But there are certain ways of improving the specificity of PSA. Before reaching a conclusion, the dictum is you have to repeat a serum PSA. Don't go by one reading only. There may be a lab error, there may be other things. So if after a week or so, after you suspect some infection or inflammation, just wait and repeat it before going into a number of tests because of the raised PSA. Then there is a PSA density, is again the PSA divided by the volume of the prostate as measured on a transrectal ultrasound. A cutoff of more than 0.15 nanogram is suspicious. Similarly, velocity, how the PSA changes, the level changes every year. So a change of more than 0.75 nanograms per year in a 4 to 10 gray area zone of serum PSA is significant. Similarly, a change of more than 0.35 in a PSA of less than 2.5 is also significant. Rates more than 2 nanograms have been associated with a quicker time to death from recurrent disease. So this shows us that there are certain additional modifications of use of PSA which can again aid us in the early detection of this cancer. Similarly, percentage of free and total PSA. Because the free PSA, more the free PSA, less the chances of malignancy, it goes more in favor of a benign pathology. And less than 10% ratio, more chances of carcinoma, more than 25% ratio, likely BPH. And then as I said previously, we have age-specific thresholds also between 40 to 50, then 50 to 60, more than 80. So you have your cutoff value. So we have to keep in mind. And one more important thing, that all these parameters change from population to population, from ethnicity to ethnicity, from Americans to Africans to Asians. So these values keep on changing. So once we are referring to the Western data, we have to understand the limitations and implications vis-a-vis our subcontinent data. And I can tell you here that the Urological Society of India is trying to formulate its own guidelines. Recently, all the urologists of the country have participated in forming guidelines for management of BPH, and all of us have participated, so that we have an Indian scenario and give our directions, our recommendations based on our patient population. And similarly, they are working on other things, including, say, a prostate. Now, what is the logic and how do we do the screening for prostatic cancer? What is the rationale? Why do we do it? Simple. Likely to reduce the prostate cancer specific mortality because you detect it early. Likely to reduce proportion of men diagnosed with advanced or metastatic disease. So this is the basic target question. But while prostate cancer mortality rates have declined since the advent of PSA testing, it is uncertain what proportion of this is due to PSA screening. Is it only because of this, or other things have also improved? So we cannot give whole credit to screening by PSA. Possibly there are other parameters as well. And as we are most of the time nowadays talking about artificial intelligence, AI, that would be one tool that could help us in identifying other important parameters which would aid the PSA screening in arriving at a better logical conclusion. Now see this slide. This is mentioned, are there any harms of screening? I mean, it's a little confusing that you are screening for a disease, and is there a possibility of harms from the screening? Yes, because performance of unnecessary biopsies and the risk associated with these procedures, sometimes we may do unnecessary biopsies. Substantial overdiagnosis, that's defined as identification of a case of prostate cancer that would not otherwise have been diagnosed during a patient's lifetime without screening. So see the scenario. Receiving a diagnosis of prostate cancer is psychologically distressing, whether it is at an early stage or an advanced stage. So you have to keep these things in mind. And then the risk of prostate cancer therapy. So these are certain, one would say, drawbacks. So we need to balance. So what is, as we are nowadays dealing or working in an atmosphere where the dictum is evidence-based medicine. So what is the evidence on screening? We cannot keep on giving vague guidelines. What is the evidence? So there are studies. There are so many studies. Just to quote a few, we have the randomized European study where men between the age of 50 and 74 in 7 European countries were registered randomly, and 83 were screened group, 83,000 were screened group, and 99,000 were controlled. And PSA on average once every 4 years was done in the screened cohort. During the median follow-up of 11 years, carcinoma prostate was diagnosed in 9.6% of the screened group, as well as in 6% of the controls as well. This is from the randomized European study. So screen group was 29% less likely to die from carcinoma prostate. So this is the point, because they were detected early. 1055 men would need to be screened and 37 cases of prostate cancer treated to prevent one death. So this was a conclusion from this study, where thousands of patients were enrolled. The positive PSA defined as 3 nanogram per ml in the most of the centers. So this was the cutoff level they used. 6-core biopsy was used, and prostate cancer diagnosis in up to 20% higher with an extended 18-core biopsy. So you do more cores, you are more likely to you find the lesion. Localized prostate cancer more common in the screened group. A definite benefit for avoiding metastatic disease. So this is the positive point of screening and early detection. And this is based on the randomized trials from 7 European countries. Similarly, there was another what's called as Gothenburg trial from Sweden. They followed many patients enrolled for 20 years, 18 years, 14 years. And at 14 years, they saw their risk of death decrease by 40%. And for every 227 screened, 12 needed to be diagnosed and to prevent one death. The proportion may be less, but the logic is there. So we can see the numbers, screening group, control groups, the numbers are shown there. So I'm just telling the nutshell what was the conclusion from the study. Another important study, what we call as PLCO study, is for prostate, lung, colorectal and ovarian cancer screening. 38,000 men each randomly assigned to annual screening or usual care. Compliance rate of PSA and DRE were 85% and 86% respectively. Usual care included up to 52% getting annual PSA and 46% getting yearly DRE, digital rectal examination. Follow-up was for around 7 to 10 years. So this is their conclusion. 116 versus 95 incidental cases per 100,000 per year in screened versus control. So this is the difference. Similarly, 2 versus 1.7 deaths per 10,000 per year in screened versus control. So this is statistically significant as well. Again, the same study, high rate of screening in control group could dilute the results. So in the control group also you had certain, so this is an area of concern, how to address this. And it was only 7 to 10 years follow-up, so possibly less, so we need more follow-up. Usually an absolute value of 4 per mil as a positive PSA may lead to underdiagnosis, because if we stick to this 4 cutoff, it may lead to underdiagnosis. 18% fewer Gleason 8 to 10 prostate cancers in the screening group. So this would be an advantage. Similarly, the USPSTF, or the United States Preventive Services Task Force review, resulted in an estimate based on data from randomized controlled trials that screened 1,000 US men from 55 to 69 years of age, and they say may prevent deaths from prostate cancer in 1.3 men in 13 years after initial screening. So this is their cutoff. I mean, I have to quote these studies because this is the basis of my talk. So you have to understand, or possibly bear with me, because you have to understand the logic of putting these studies here. Now these were the certain important multicentric, multi-populational studies that have been conducted in this regard and some of the results. But the important point here is that you have the screening, you have the population, you have the risks. How do we finally analyze and manage the situation? And this is the trick that is called shared decision making. Decision making that involves the sharing of information between the patient and the clinician, and joint participation in decision making process should be an integral component of our PSA screening. So we cannot offer this screening to everyone. We have to make patients, counsel them, tell them the risk benefits. The local healthcare provider is to be involved. So that is why this is important. It's not only the urologist. It is the primary care physician. It is maybe the surgeon or other physicians who see the patients first. It is their role also. They have to educate, they have to direct the patients, and there has to be a shared decision to actually get a benefit in an individual patient rather than giving a general statement for a whole population. The usual decision is tools that help patients understand the benefits and harms of undergoing screening may facilitate. So you have to make the patient aware. There is a lot of literature available in all the languages, and some of them have been translated into local language also. So even in Kashmiri or Urdu, we can make the patient understand that these are the risks and benefits. Are you willing for the screening? Unless and until the patient is willing, his initial primary care physician is involved, we cannot achieve success in at least this screening program. So these are the various current literature says what are the categories and components of these decision makings, what are the parameters. As we see, the main screening test is PSA. Then we have to assess the probability of prostate cancer diagnosis after prostate screening. What are the potential benefits? They are all mentioned here. Among 1,000 men invited to undergo screening, approximately 5 will die from prostate cancer and 1.3 will avoid from prostate cancer owing to screening in 13-year period after screening. Just a couple of minutes more. So these are all parameters here mentioned, that these are the things that we keep in mind and we try to arrive at a conclusion. Again, other parameters like the age, the race, the family history, and then the perception, aspirations, and expectations of the patient, all are equally important. A simple algorithm that once in the you have a positive screen, so you have to have the confirmative PSA test again, confirm it. If it is negative, it goes again to the yearly or whatever the protocol screening. But if it is positive, then we may use some blood and other tests like PSA, antigens and other things, cancer antigens we have, or other markers, although they don't have much role, but they can aid in further diagnosis. If they say it's a low risk indicating, just monitor. If it is high risk, go for a biopsy or a multiparametric MRI. If it is negative, standard biopsy. If it is positive, then MRI guided fusion biopsy with or without standard biopsy. So this is the actual protocol, how we manage once we pick a patient in screening. So the recommendations here are, again, these are the US Preventive Task Force recommendation for population between 55 to 69 and for men to be older than 70. The decision to be screened for prostate cancer should be individual one. There is a grade C evidence. For elderly, grade D, you may not screen at all. Informed decision making, as I said, so we have to involve all the people who are involved in the management of that patient, his family, the patient itself, the primary healthcare provider, the epidemiologist and all, so that we can tell him the risk-benefit ratios, other screening tests and the treatment options. For localized, we do a radical prostatectomy. For locally advanced, we can then have to go for palliative as well as for the metastatic disease. And these are the EUA recommendations. This is just for a ready reference. Otherwise, we all know it, that do not subject men to PSA testing without counseling them on potential risk and benefits. And this is we can see the level of strength of evidence and their ratings. So they're all there for various age groups from the European Association of Urology. And this is from the American Association of Urology. They have given their own guidelines based on the age groups and whether African American or Asians. And the final question that I posed, that we had asked initially to address, does it make a difference? So here we have to understand, prostate cancer often has no symptoms until the disease is advanced, and screening may help detect cancer early when the chance of treatment success are high. But there is no one-size-fits-all approach to prostate screening. So we cannot generalize. Although PSA is the main screening test, prostate cancer can only be diagnosed by prostate biopsy. And early detection, that is the key. AUA recognized the choice to be screened in a personal one, and men should talk to their healthcare provider whether prostate cancer testing is right for them. And finally, who to screen? Men who benefit the most from routine screening are between the ages of 55 and 69, and routine screening is not recommended in men under the age of 40 or over 70 years. And who are at higher risk? Men between the age of 40 and 54 years, and African American, or who has a father, brother or son who has a prostatic cancer. These are the people who will be maximum benefited by screening and early detection. Thank you.
Thank you, Dr. Arif, for an exhaustive and elaborative talk on a very vital issue of carcinoma prostate. As we all know, the early detection of malignancy is definitely helpful, and the times have changed when we would see the patients in the late stages with metastasis, because the symptomatology and symptom groups in these patients are same as in the benign prostatic hyperplasia. The game changer has been the serum PSA. And with its limitations and with its controversies attached to you, which you elaborated in detail, and you rightly said that the early detection is the early detection of malignancy is most important. And we had times when we would go on a biopsy, digital rectal biopsy and finger guided biopsy. The things have changed over a period of time. And though your talk was on the screening, but you, as all of us know, that the early detection with the other modalities has definitely helped these patients. And we would definitely, and as you mentioned in your talk about the artificial intelligence, and we have now the biopsies, which is prostate biopsy artificial intelligence panel. This helps now in quantifying the tumor and early detection of tumor, which is very, very low grade, and in few slides. So that would be the, in fact, the game changer in future. Exactly, that you already touched, and it was a very exhaustive and elaborative talk. And I would request my chairpersons if they have any comment to make about the Dr. Arif's talk.
We are already short of time.
So, yes, Dr. Mahmood has a point.
Thank you, Dr. Thank you, Dr. Arif. Take on, beta.
Please, sir, please. Sir. Sir.
PSA. It is one of the modern things.
Sir.
After how many months I should get PSA repeated?
If it is normal, yearly.
No, if it is more.
Then you have to come to 6 months or 3 months, sir.
Okay,
depending
sir,
on
thank
the
you.
level.
I have one interesting thing.
Sir.
For prostate. Let me take you to my student life. I am talking in 1959.
Sir.
I was a surgical student, final year. I appeared for surgery. My teacher was late and great, Chalpati Naidu. I was his pet student. He told me what is the dose of citalopram for prostate that time. I said, I was not knowing. I said 1 milligram. He said, Kashmiri, do it in Kashmir. I will throw you from the window. And I went to my registrars. They were not knowing.
Yes.
Then I went to All India Institute as postgraduate. I opened Rodney Smith book, yes. Charlie Schwab.
Yes.
I saw there the dose was 45 milligrams. 1 milligram to be given to rats. Now then what happened? We were giving this 45 milligram all over the world, the dose. Then the question went to French territory. Mitterrand was the president of French Republic. He got severe prostate. Yes. He was given 45 milligram. Luckily or unluckily, he became female-like.
Yes.
Once he became female-like, then they investigated.
Yes.
Now the dose is only 1 milligram.
Yes.
This is what I am telling you.
True, sir. True, sir.
Surgery, surgical medicines, all medicine are changing.
Yes.
It is not the Holy Quran.
True, sir.
Therefore, have always the open mind.
True, sir. True, sir.
In earlier days, we used to be afraid of PSA.
Yes.
Now, I think we are not.
We are not.
I was diagnosed in 83.
Sir.
My prostate became infected. 83 days as Dr. Saab has got a prostate. Luckily, it was done.
Thank you.
Thank you, sir. Thank you. Dr. Mahmood, you had a point.
Thank you, sir. Arif, as usual, your lectures are very exhaustive and they are research oriented. Probably at this fag end of the morning session, I don't think, I feel that it should have been placed higher up in the sequence. But all the same, I think in our next meeting in SKIMS, we should have a panel discussion on this. What would be the scope of screening for prostate cancer? And that would, I think, serve the real purpose. But all the same, I thank you for this exhaustive lecture. It was definitely an eye-opener for all of us.
Thank you, sir.
And I hope you will continue to present such papers in near future as well. Thank you very much.
Thank you, Dr. Arif.
Thank you.
Thank you, sir. May I invite the next speaker, Dr. Ashik Hussain. He will be talking about partial nephrectomy for T1 renal masses, challenge and outcome. Dr. Ashik.
वीडियो प्ले करना है
Respected teachers, respected faculty members, and respected delegates, I am Dr. Ashok Hussain. I will be presenting my work, Partial Nephrectomy for T1 Renal Masses, Challenges and Outcome. Renal cell cancer, as you all know, occurs around 1 to 2 per lakh of the population. It's slightly more common in men than in females. And asymptomatic incidental diagnosis are nowadays increasing because of the increased use of the radiological investigations, ultrasound, CT, and sometimes rarely there's a dull line pain, and nowadays very rare presentation can be hematuria or anemia. We have ultrasound for the diagnosis, we have contrast CTs of the abdomen and pelvis, and CT angio to know about the exact vascular anatomy of the renal masses, the feeding vessels, how many vessels the kidney is being supplied, so that all information we get from the CT angio. Now, so far as the management is concerned, it's not only the tumor, there are various factors like tumor factors, anatomical factors, and clinical factors. So size of the mass also determines what sort of treatment you are offering to the patient. Sometimes there can be simultaneous bilateral renal masses. The scenario is different, so the number is also different. And at what stage you have diagnosed a case of renal mass, that also decides what sort of treatment we are offering to the patient. So far as the anatomical factors are concerned, we have to be very sure whether this is invading into the main renal vessels, invasion into the pelvic calcial system. That can be detected preoperatively by quality imaging in the form of a CT urograms and CCT abdomens, extension into Gerota's fascia and surrounding structures. So that determines the stage and our planning of treatment. And so far as the patient and clinical factors are concerned, so is there any concomitant infection, how much is the obesity, what is the body habitus, any deformity, any coagulopathy, hypertension, and renal failure. So that also determines what should be our priority, whether we can go for a nephron sparing, whether we can go for radical nephrectomy. So all these three factors, tumor factors, anatomic factors, and clinical factors combined together makes the urologist to reach a conclusion, what treatment I am offering to the patient. Now I'll be presenting my work. So all this work has been carried in a remote district hospital of the Valley District Hospital, Pulwama. There was no expert help. Support staff was not well acquainted. There is handful of equipments and no second opinion. So I am presenting my work of around 10 patients in which open partial nephrectomy was done in 8 cases and lap partial nephrectomy was done in 2. Although I have crossed the now 4, but at the time of submission it was only 2 lap partial nephrectomies. Time period was last 3 years. Other than the baseline investigations, ultrasound, CT abdomen, CT urograms, and CT angio was also obtained. And this was the usual post-operative protocol, nothing significant. Total number of patients enrolled in this study were 10. Age range was 30 years to 75 years. Mean age was around 45 years. And slightly more common in male than in females. Mid-age is the common age group in which this renal mass strikes the patient. So 30 to 50 was the common age group, although 2 patients were below 50 and 3 patients were above 50 years of age. And out of these 10, it was T1A less than 4 centimeter, I will say. We stage the renal masses less than 7 as T1 masses. And then there is T1A and T1B. In T1A, it is less than 4 centimeter, and T1B is more than 4 but less than 7 centimeters. So most of my cases out of 10, 9 cases were T1A, that means they were less than 4 centimeter, and 1 of the cases was T1B mass. So, but all the cases were T1 masses only. So right side was relatively on the higher side, left, but there was no bilateral tumors. Upper pole around 2 patients, mid pole 3 patients, and lower pole were 5 patients. And initially all the cases were lower pole, which I did. And initially it took us some time, especially in the lab, more than 4 hours also in lab partial nephrectomies. And as the time progressed, although not much of experience, only 10 cases, but our time reduced to less than 3 hours. And this was our final histopathology. Renal cell carcinoma was detected in 7 out of 10, means 70% of the tumors had renal masses, renal cell carcinoma, 2 had oncocytoma, and 1 was post-operatively diagnosed to have a benign pathology. And Alhamdulillah, we should be thankful that out of 10, all the 10 cases had resection margins were free of the tumor. I am presenting one of the index cases. She is a 50-year-old female who presented with an incidental diagnosis of left renal mass. CT abdomen pelvis revealed a left lower polar enhancing mass measuring around 5 to 4 centimeter rising from the left lower polar side. Nephrometry score was around 6A, planned for lab partial nephrectomy. As you can see, this is a non-contrast image, the bulging both endophytic as well as the exophytic component of the tumor in the left renal kidney, left kidney. And this is the contrast image, heterogeneously enhancing lesion arising from the left lower pole of the kidney. So lab partial nephrectomy was planned. So I'll be here playing the video how we have done this case. Although the quality of the video, I am apologize for that because this is
It's playing down. Yes.
Yes. Here you can see the renal hilum being dissected. It's a fast forward image so that I don't waste much of the time. The kidney has been completely mobilized. You can see that we have created 2 windows. One is below the renal hilum and one is above the renal hilum, so that we have a complete control of the renal hilum. And after that dissection, we are now defatting the tumor. As you can see, the quality of the video may not be that good because the mobile recording, we don't have a recorder available there. This is our renal mass. Defatting around the tumor is being done laparoscopically, and surrounding areas is being freed so that we can have clear, healthy parenchymal tissue around the tumor quite visible. And then we can start, we can plan our resection accordingly. The posterior aspect of the, after lifting the kidney, the posterior aspect of the kidney is also being completely mobilized. And After that, we'll be planning to clamp the renal hilum so that we don't get any issues of bleeding during the surgery. So we are making sure that between the renal artery and renal vein, there is a good plane and we can put in the laparoscopic clips. This is the renal artery which is being clipped laparoscopically, not clipped, actually clamped. And again the renal vein again will be clamped. Laparoscopic clamps being put in place so that we have less of the bleeding and we can, after taking it, now we start the resection from the healthy renal margins. This is just some oozing because of some congestion in the renal parenchyma secondary to the clamping of vessels. As such, there was no active bleeding. It is only the some pent up or I will say congested blood which is coming out. No fresh spurters or vein was there. So we, as you can clearly see, we are going in the healthy areas of the kidney, and inferiorly we are now going. Here tumor was a bit closer. Then you will see it in the video, I took another bite so that we obtain the healthy resection lines. Now we will be coming from the superior aspect of the tumor. The superior aspect of the tumor we are resecting. You can see the clearly healthy parenchyma as you can demarcate between the tumor and the healthy parenchyma. We are resecting the tumor, leaving behind a healthy renal parenchymal bed. So that's our bed in place. After saline irrigations, we examine it for any residual disease which has been left behind. So I was a bit skeptical on the lower side, so I took one more chunk from the lower side. After this, we clean it and examine it properly. Any gross, some hemostasis. After that, I'll be planning a renography. We'll be closing the kidney in 2 layers, pelvic calcium system and renal bleeders in 1 layer, and the capsule in 2 layers, so that after we remove the clamps, there is no bleeding and patient does well. We have started our renography. We go through the bed of the tumor also, so that the vessels and any open calyx is also taken by the suture. And then we come out via the lower margin through the capsule of the kidney again back. So it was done in 2 layers. We are just now putting an anchor suture in place, keeping the tail in place so that I come back from the other side. And once we complete the 2 layers, the thread is tied to the first knot so that it completes the 2-layer closure of the kidney. Again, you can see we take the central area first. Sir, just 2 minutes more, sir. This is, we have reached the lower portion area. The pressure being applied so that these now again will be coming back. The 2-layer closure is being, now I am coming back from the lower side to reach the original site of where I have started the suturing, so that we have a complete hemostatic control of the resection area, lower pole. Now you can clearly see the lower pole has been completely closed, giving it a shape of almost kidney back. Additional bolstering suture so that The suture line remains stable after we remove the clamps. And after this, we'll be removing the clamps. There is some more movement of the video because of handheld mobile phone. So we'll be just closing it so that we reach the. Now you can see after this we'll be just removing the laparoscopic clamps and look for any bleeding and the healthy. The initial corner suture was in place. Now we are here, we can remove the renal artery has been removed, clamp. Now renal vein is being released. That's it. And
Thank you. Thank you, Dr. Ashik, for a nice video and a nice presentation. We all know that embarking on such procedures, especially in the peripheral hospitals, is not an easy job, and you need to have a lion's heart to embark on such procedures.
Yes, sir.
And well, we will come to the histopathology in a moment. And we saw that what you had said about the
resection margins are
yes, free of tumor.
Free of the tumor, and it was a papillary carcinoma.
That was evident from your present video also.
This is our summary. Currently, majority of the renal tumor, renal mass are being managed by nephron-saving surgeries. Success rate is good. Incidence complication is low. Although laparoscopic partial nephrectomy is equally effective in terms of oncological outcome as compared to open, and in addition has an advantage of being minimally invasive with quick patient recovery. So, NSS is the minimally invasive procedure of choice for T1 renal masses, with laparoscopic mode equally being oncologically effective, in addition to being minimally invasive with faster patient recovery. They say, I could live without you, but the life is more amazing with the two of us. Thank you.
Well, thank you for a nice presentation. And I was saying that embarking on such procedures, especially in the peripheral sector, is not a small job. It's you need to have a big lion's heart to do that. And we know that you have a big heart, and then you have been trained well, and you would excel. And compliments and applause for the procedure he has done in a private sector. Well, what
I just have to make a comment, sir.
Wait a second, sir. So what I just wanted to make a comment and query about the procedure which you showed. You use bulldogs to block both renal vein and artery. And is it important to block both?
Yes, sir. In initial cases, we did only renal artery only, although there was more of venous ooze, and it is quite disturbing.
Right. And then about the sutures, and yes, what is the suture material which you use for the renal?
Sir, I used 20 Vicryl only. And
I have a comment on that because initially, if you want to make your life comfortable, you have the barbed wire. I was seeing barbed wire being used everybody left and right, and then the barbed wire is available everywhere, and you do not need to put a knot, and then you go through and then come out quickly. You would be saving half an hour of
ischemia time also is reduced.
So that was right. And one question I had about the benign biopsy, histopathological report coming benign. I want to know what was the modality of investigation which was used for diagnosing this patient.
Sir, actually, this patient has had some infective pathology in the lower pole of the kidney. For a long time, the patient had been, it was quite good size, around 4 to 5 centimeter, iso dense. It was not that enhancing lesion in the lower pole, iso enhancing lesion, similar enhancement as that of the renal parenchyma in post-contrast images. And after receiving weeks and weeks of antibiotics.
What was the modality used for, it was CT?
Yes, CT.
What about the MRI? Why did you go for an MRI?
No.
So because if you have such a situation where there is a doubt about, and you are embarking on a procedure which can very well, luckily this was a nephron sparing surgery. If you are embarking on a procedure where there is a chance of converting to the radical procedure, you should be sure before going on to it. And I think MRI is available, and MRI could have been done for that. And the comment from the floor.
I want to congratulate Dr. Ashik for such a wonderful surgery, and at the same time compliment Professor Salimani, sir.
Thank you,
your efforts have been rewarded.
Sir, before I conclude, I would like to say this is all credit goes to my teachers and my home. They have trained me to a level that I have contributed a bit at a peripheral hospital level, whether it is any endourological procedure or it is laparoscopic urology. Credit goes to my
You're
teachers
doing a
from
wonderful
KIMS and
job.
from
Thank you
this
so
hospital.
much. You're doing a wonderful
Thank you,
job.
sir.
You're making us proud.
Hello,
Thank you.
Dr. Ashik.
Thank you.
You did a wonderful job, no doubt. But you guys just let me know, how did you confirm that you have not transected the pelvic calyceal system?
Yes, during the resection, there was a lumen which was quite visible in the video also.
Yes, it was
And I made it sure that I take it from the base of the central part of the so that, and there was no urinary leak in the post-op period as well.
So this is just a suggestion. This viewer, since you are saying that you have only done 10 cases,
Yes,
so
sir.
better is to put in a ureteric catheter or just to check with a methylene
Yes,
blue whether-
I had attended recently a modern, this laparoscopic workshop on partial nephrectomies, where many big authorities all over the country were of the opinion, unless and until you don't have, although it's a precautionary thing to put in a DJ stent, they were of the opinion if there is no quite obstruction in the pelvic system, there is not much need to put in a DJ
But
stent.
in this case, this tumor had a very good amount endophytic element.
Yes.
Well, regarding the whether we put in a ureteric catheter before and put methylene blue or not, and then whether we do a DJ stenting or not, our experience at Sher Kashmir University of Medical Sciences is that in none of the cases we put in a DJ stent or a ureteric catheter for checking for the leak. What usually suffices is a rhinography. You take first layer and that closes it, and then afterwards you do the rhinography with barbed. Thank you very much,
Thank you, sir.
and thank you, co-chairpersons, for conducting this program, and we thank the organizers.
Thank
and
you, sir.
hand back the mic to the organizers.
I thank all the chairpersons for their valuable time and all the speakers. And I request Professor O.J. Shah to please come on the stage and felicitate our chairpersons.
The chairs.
Professor Mohammad Salim Wani, sir. Dr. Sajid Bazaz. Dr. Zuhur Gilkar. Dr. Manzoor Ahmad Chalku. Sir, I request you to kindly felicitate our speakers also. Professor Gulzar Mufti, sir. Felicitation. Yes, sir. Speaker. चलो बेटा Professor Mohammad Salim Wani, sir. Professor Arif Hamid, sir. Dr. Ashik Hussain. One more, sir. Dr. Ashik is this. Thank you, sir. With this, we conclude the session and we have a small lunch break of around 20 minutes. I request all of you to proceed for the lunch.